Good morning and welcome to the Somerset board here in the Luttrell Room at County Hall in Taunton. Can I just check before we go any further, can you hear us online? There's a thumbs up from Sarah at last. We got somebody. Excellent. Welcome to the meeting. I'm Councillor Bill Revens. I chair the Somerset board as part of my role as leader of Somerset Council, and I would be formally welcoming Councillor Mark Healy to the room, but I can see he's not in his chair. So if he does materialise, we'll do that formal welcome at this point. I'll just do some housekeeping announcements. So our agenda pack is available on ModGov or from the council website, and that link is sent out to all members of the board. So normal meeting procedures. If you're online, please keep your camera off and microphone off, but turn them on when you speak. This helps with background noise and call quality, and does help us run smoothly. If you do invite you to speak, could you just state who you are, and that helps us for benefit anybody else listening in. Please only use the chat function for the purposes of this meeting, please. That's where all questions need to be. The questions need to be through verbal communication, please, not through popping them on the chat. And these agendas are viewed electronically. Please can you refer to the page numbers if from the published pack if you're referring to anything in the papers. And we're not expecting a fire alarm this morning. Should that happen, please follow the staff. And we have the fire service here to assist us in that regard as well. And we'll look to the expertise. Item 1 is apologies for absence.
Thank you, Chair. Good morning. In terms of apologies for absence, we've had apologies from Dr. Rima Makarim, Sarah James, Hilary Robinson, Catherine Nolan, Mark Cook, Michelle Allen. We've also had apologies from Mel Locke, with Emily Fulbuck attending as a substitution, Claire Winter with Richard Selwyn substituting in, and Gavin Ellis with Gerald Taylor substituting in. And we've got a number of people online as well as in the room, Chair, just to make you aware.
Thank you very much, and particular welcome to those people who are substituting. Liz?
Yeah, we have apologies from Councillor Graham Oakes, who's on annual leave, and I would expect apologies from Councillor Smith-Roberts, as this is one of her work days.
Understood. Okay, and welcome to those who are substituting in today, and we accept those apologies as given. So minutes from the previous meeting, are we happy that they are a record? I note that we've got a correction that Sarah James' recording is not in attendance, but she wasn't online. So we will amend the minutes accordingly. Heather?
Forgive me, I didn't pick anything up in terms of inaccuracies in a minute, but I just wondered if perhaps when we've done the accuracy side of things, if there's an update on the actions that were placed. Those are 1 or 2 actions. Just want to make sure they'd all been done.
Yeah, of course. Councillor Wakefield?
Yeah, I apologise if I didn't give apologies. I was actually in New Zealand at the time of that meeting. I had certainly intended to, and I'm sure I asked my PA to do it. So I apologise if they weren't given at the meeting, and I'd like to apologise to the other members if that didn't happen.
Apologies for the lack of apologies, and apologies for the apologies. Yeah, I think I get that. Thank you. Well, I think we'll just note the apology, if that's okay. Do we just want to just look at the action log as well? Is there anything that we need to update on?
Yeah, so apologies. That's right. I haven't actually got any notes from the actions from the previous meeting on that one. That's something I'll have to follow up with. Apologies, that's slipped by since I've joined the team post that meeting. I'll follow that one up though. I do have a note that the pharmaceutical needs assessment did go out for consultation though, and has come back, and there's no change required. So I do have a follow up on that action that was covered at the meeting, but none of the others that we mentioned. I'll get back to you on that, Councillor. Apologies.
Thank you. And other than on agenda item 3, other than items that are already noted in declarations, are there any other declarations of interest we have on the agenda? I'm not seeing anybody indicating, and we have no public question times under agenda item 4. we move swiftly on to agenda number 5, which is our joint strategic needs assessment update. And like to invite Dr. Orla Dunn, our public health consultant, to present, please.
Lovely, thank you. So I'm bringing the new design of our joint strategic needs assessment along to the board this morning. This is a sort of annual duty that the Somerset board has to undertake and is delegated to the Public Health Intelligence team. So the purpose of a joint strategic needs assessment is really to provide that high level strategic overview of the data and the information that we have about the Somerset population. And then that's meant to drive some of our high level strategies like the Improving Lives strategy. And the lower level detail, so the bit that really unpicks the detail which is required for commissioning and service design, that's often sitting in other documents like health needs assessments, excuse me, and other sort of documents like, for instance, fact sheets or briefing sheets. So I wanted to just give you an overview really of our new design that we're having. So we've moved towards a much more of a dashboard based approach. This has a number of advantages over the previous sort of websites with links and embedded graphs in that it's much easier for us to keep up to date, which means that when people are looking at the data, it's being automatically sucked in, so it's kept up to date. And we've also had a bit of a revamp looking at the different areas and seeing how those align to the overarching strategies across the whole of the Somerset system. So at the moment, it's in a bit of a kind of hidden area. So this is the link. If you start clicking on that link, you'll find that some of the links back to the main bit may shoot you back into the old version, but subject to sort of people's favourable opinion today, we'll make that fully live after the meeting. So this is our sort of entrance page. So we've got our dashboards up the top and then a little bit of further information underneath about what the JSNA is. And if I sort of bring those up a little bit larger, we've separated it at the moment, and this is absolutely still a work in progress, but we've separated it at the moment into 6 key dashboard areas. So the first one is on population, and that's really facts and figures about our Somerset population, looking at key outcomes like life expectancy, healthy life expectancy, but also looking at some of the groups that experience some of our main inequalities and groups who we want to focus on because they're of particular importance within the Somerset system, like, for instance, our more rural communities or our coastal communities. We then have a section on beginning well, which is really aimed at covering issues that are particularly pertinent within the sort of the birth to start of school period. And we've covered issues here like, for instance, childhood vaccination, child health, complex needs, and as I say, and school sort of factors and education factors. What I should perhaps say is just to pause is that we're conscious that a lot of good data exists in the rest of the Somerset Council and in fact wider systems already, and we're not aiming to reinvent the wheel with the JSNA. We want to be able to, where that analysis and data is presented elsewhere, is really just introduce the topics and then move people over. We don't want to reinvent wheels that are running quite excellently elsewhere in the system. We've then got a section called Developing Well, and we wanted to cover the school years into sort of early adult years here, and covering a number of issues actually around school. So we have our school survey, which we'll be pulling data through. We've got issues that are particularly relevant for young adults like self-harm and also substance misuse. Then we have our living well section. This is quite a large section at the moment. So as we develop it, we may look at that in time. But at the moment, it's got sort of three main elements to it. So it's got looking at some of the major conditions that cause ill health and disability within Somerset, looking at the major risk factors that underpin the development of those conditions, and then also looking at the wider determinants and the living conditions, which can add another layer on top of the complexity of that for people. We then got a staying healthy section where we're focusing very much on disease prevention. So that's issues around early diagnosis, screening, vaccination, and some of the prevention programs that are starting to come into place now. So an example here would be the National Diabetes Prevention Programme. So you can now get onto programs that will both reduce your risk of diabetes and actually, even after a diagnosis of diabetes, help you to move back into a pre-diabetic state. And then we have the last section, and I'm absolutely open to suggestions on what to call this. At the moment, we've called it end of life, which, I don't know, it's a bit awkward. I can't tell you how many times we've battered around ideas here, but we've put issues that are sort of more pertinent towards the end of life. So frailty, falls, causes of death, premature mortality, suicide. We've also tried to focus on other things around things like independent living, because that's obviously one of our key strategy areas. And then we have our evidence base, which is, we've just given it a bit of a revamp, but it's basically the same as last time. That's where we're holding a lot of those more detailed documents that I mentioned. And then finally, the localities, which is looking at data at a smaller geography than the whole Somerset population. And I'll just put up here a little bit of information about the JSNA. We've put that deliberately at the bottom of the page because you only really need to read that once, and then you're most interested in the dashboard. So I just wanted to move on to a few of the JSNA pages just to give a bit of a flavour of the design approach we're taking. So when you click on one of the links, you get moved into one of the dashboard top areas. And this would give you an overview of the contents within that. At the bottom of the screen, I've chopped it off for the slide, but you can navigate back and forth within there. But you can jump into any of those areas, or you can sequence through in turn. And then the main pages, we've tried to take a bit of a standardized approach. So on this section, we've put information which is going to stay fairly static. So it's about the importance of that data point, why it's relevant, and a bit of a help to understand it and interpret it. In this section, and this is all automated, we have key Somerset outcomes in words. So we won't need to keep changing that. If the data changes overnight, this will still work. It will still be relevant. We then have the graph sections here and presenting the data, and that should stay up to date. And then a resources section where we can push people on to policy drivers or more information, say health needs assessment, for instance. However, we're trying to also take advantage of some of our other abilities in presenting data. So, for example, this is data on deprivation, and we've used our mapping capability to perhaps have a slightly more engaging page than a page of graphs. We've used diagrams and images within here. So this is our page, which is introducing our inclusion health groups area. And as the pages develop, we will be aiming to put pages in to go into more detail on each of those vulnerable groups. We've also covered the protected characteristics. The inequalities within our populations are very important, and that's a thread that really runs through all of our strategic aims within the council. And we've given an overview of the numbers of people within each of those protected characteristic groups. And again, we'll be looking where we can to develop further pages that give a bit more detail on what we understand about those groups. We are drawing on international data at times. And again, this is just giving another flavour of the types of presentations we can do. So this is data from the Global Burden of Disease analysis, and it's highlighting the key risk factors that drive the adverse health outcomes within the Somerset population. So we're highlighting what's driving our strategy. So this is why we are particularly focusing on smoking, for instance, because you can see in the younger age groups, and in fact for the whole population, that is the risk factor which is most driving ill health. It's got its influence across a number of health conditions, but overall collected together, that is the most important one. But you can also see where some of our other policy drivers come for focus on, for instance, high blood pressure, which is a cross-system priority with the ICB as well. And then we've linked through to government policy drivers. So, for example, this is the major conditions strategy, which again is giving us a focus on the Somerset population, not massively different from the national population. And this gives more information on those health conditions. And we're developing pages, and we will have a few more pages coming along on that. So this is probably the advantage for people who have a screen. You can zoom in. I think it's probably a challenge to the eyesight if you're just relying on your eyesight. But this is giving you a bit of an overall map of where we're going at the moment. As I say, it's all subject to a lot of further consultation and development. The light coloured boxes are the ones that are already live, and the dark boxes are the ones where we have plans. And particularly where I've got the sort of pluses, I couldn't fit it onto the diagram, otherwise it would have been really minute, but they will spawn some other pages under them as well. So that gives a little bit of an overview of the topic areas that we're planning to go into in more detail. So we are continuing to produce pages at the moment. We currently have about 26 that are live. Our final goal at the moment is to have about 80 pages in full. And I think at this stage, we're particularly looking at improving our inclusion of qualitative data, and also looking at more of those infographic approaches which appear in a lot of council reports and ICB reports particularly. I mentioned that we're linking off to the other council websites like Somerset Intelligence and Somerset Trends. We will be removing some of the old legacy pages on Somerset Intelligence pages now. We're going live with this new one, and we're working really closely with the wider business analyst team to make that a smooth process. We're planning to do a lot of usability testing and getting a lot of partnership input. So on the back of the previous presentation of this at the corporate leadership team, we've started having meetings with key individuals in other parts of the council to make sure that those high level data stories that drive their commissioning approaches are reflected within the JSNA. And I'm sure that we will be developing some further pages based on the feedback that we're collectively getting. So I'll pause there and see if anybody has any questions.
Thank you very much. And we'll go for Heather first.
Thank you, and thanks so much for bringing this. I really do like the dashboard approach. I think that's really good. I've always liked the stuff that comes out of the work from the JSNA anyway. It's really good to have that kind of data. A couple of things I was just thinking about, and I don't want to bandy about with words, but certainly I was expecting, with all those fabulous ones, almost dying well, which isn't quite what that bucket is about. Yeah. And nor is it necessarily end of life. And I just thought, if I was somebody who was worried about someone, or had myself conditions around falls and frailty. It might be towards end of life, but that's just a thing. But more importantly, I think it's really good. I'm sure it'll be very easy to navigate. In other sets of data I've seen, or databases essentially, sometimes the opportunity to overlay things is really important. So that you can see, like, say, when you can see the deprivation areas, but then also the prevalence of something else. You know, I've seen, we have some in children's where we can say overlay different types of boundaries and school catchments and types of schools, and you can overlay them and see them in the map. I'm not saying this is anything you need to be doing, but when you're thinking about further things and people tell you what you need, that capacity to see two things together might be helpful as you develop your maps. But I think it's really interesting stuff, I think. So thank you.
Thank you.
Jonathan.
Thank you all. It's really helpful. Just a couple of points and a question really. So I think the format of this makes it so much more accessible than what we've had before, and there's a massive opportunity then to see how this links together with everything else. Because I think sometimes the JSNA data has been sort of a bit buried. It's used really actively by kind of council colleagues, but I think elsewhere in the system it's been more difficult to access, and this sort of format really helps. There's an item on the agenda later around the digital data and technology programme and bringing together this sort of data with all the other data through a linked data platform. I just wondered whether you would kind of comment on your thoughts about how all this comes together with some of the other data that we've got in the system and how we most actively use it. So that was one. And I guess the other point was just I kind of launched into the very bottom of this when you gave us the link and went into the primary care network data and sort of click through that, because again there's some really valuable stuff there that we could and should be getting out to people more locally, because it's got some amazing insights about what's going on within communities. One of the weaknesses I noted was that the data only goes, but it's from 2021, 22, and so there is an issue about timeliness of data and some of this being a few years out of date, and it's probably just because this is nationally reported and validated data and there's all of that stuff. But I wonder whether you could just comment a little bit on the links with the linked data platform and then kind of timeliness and how we get to a point where we've got data that's more up to date from a time perspective.
Yes, of course. So yeah, the pages that we're designing here are often drawing up the nationally sort of published data. That isn't always quite as timely, although I'll come on to the timeliness of the profiles in a moment. But it does enable us to get that comparison, to compare ourselves with other areas and with national data. So we'll be continuing to exploit that opportunity to sort of benchmark ourselves against other areas. I think the federated data platform that we'll hear about will give us huge ability to dive into our Somerset data, and I think that's probably an example of where we would send people off to another dashboard area to get more detail, and it probably would enable us to do some of those overlays and things like that as well, which is at the moment probably a little beyond the JSNA stuff. So, and the other advantage, and I'm on the limits of my technological understanding of it, but we can use APIs which automatically pull that data through, so it will be kept as up to date as the data that sits behind it is. So we won't, the PCM profiles, they're static profiles, they've been published, but they don't keep themselves up to date. They are actually going to be updated by the end of this month to coincide with the pharmaceutical needs assessment. So that is coming, a bit of an update job is going on at the moment on those. But yes, I don't want to steal any of Lucy's thunder, but we will have an amazing depth of information on our Somerset population at that point. But what we won't have is the equivalent depth of information from other populations. So where we want to do the comparison, we'll probably need to stick with the national data.
Thank you. Whoever's driving the slides, I wonder if we could just pop back to the one with the small print in it. Sorry, I was just wondering whether we were happy that we're capturing everything in the school age section, particularly as relates to SEND. I'm not thinking particularly about SEMH and CAMS, whether we're capturing that data, because I know that we're seeing more higher than anticipated young people who are representing with social, emotional, and mental health needs. And for me, that is it will move through all of those age groups right up to end of life.
Yeah.
If we don't get a grip on that one.
Absolutely. We've had some really useful meetings with Amelia to talk about some of that data. So we've got specific pages, for example, around EHCP outcomes and the sort of shift to the more complex end of things. That page is being planned. Some of the other pages that you mentioned, so SEND, will probably be in those sort of plus sections where, as you say, it's not a group that only have an issue in a childhood. They, as you say, have an issue across the whole lifespan that we need to be aware of and plan for. So we haven't put them in one of our sort of life point groupings. We've put them more in a population grouping area.
And moving on slightly, but also thinking about exclusion and also contact with criminal justice system and the youth offending team, whether because that
Yes.
I would indicate is a determinant of health as well.
Yes, I mean, they're certainly a vulnerable group, so we'd probably put something in there. We have got plans to put in something around community safety, but that's, I mean, this is a good example of how the sort of talking to people, you suddenly go, oh, actually, that would be quite a good area to put in. So I think that's definitely one we could look at.
I'm not quite sure who won the race to my right. I think it was Heather.
I think Bill's exactly spot on, and I think that's again where my kind of overlay question is about, because again, it's that thing about, you know, you can get into predictive when you can see certain conditions and certain circumstances being in place. So that's very interesting. And also there's something about interrogating and reporting. So in terms of it's lovely data, it's great data, but I mean, this may be a discussion for later on, but it's that stuff about if you want to know a particular question, you want to ask a question, can we get certain data out? And absolutely on that, the bit about major health risk factors, that thing, as you say, contact with criminal justice system or open to exploitation or any of those things, and the absence from school is a protective factor. I'm sure Amelia will have talked to you about that, so I'm sure I bet that will be in your thought process for the next iteration. But I think it is that overlaying and triangulation, if you like, which can then help you understand the size of the problem and the complexity of the problem, but then start to predict it.
No, thank you. And first of all, I'd like to start off by thanking Orla and the team for all this hard work. When I said, oh, I'd quite like a different format of the JSNA, wasn't met with overwhelming joy from the team, but they've done a great job. So thank you, first of all, to that. I think just to pick up something Jonathan said, actually, the JSNA is only as good as how it's used and what it's used for. So we are very reliant on you engaging with this, talking to us about what you would like in it, and also sharing it with teams. I don't want to go above and beyond, but we could come out to senior management teams to do a quick rattle through to help you use it to shine a light on some of the outcome areas that are not as good in Somerset for our population as we would expect them to be. And I think, Bill, just to pick up your point, I share your concerns about children and the outcomes we're seeing for them. I think what this tool does is it shines a light on that. I'm looking at the developing well one, and percentage of children achieving a good level of development, Somerset exceeds England. But when you look at our free school meals population, our cohort, they're far below England. And so I think this tool shines a light on areas where we have to do more and look more. And it might be the JSNA doesn't answer all those questions. It just helps us in a huge population and a vast area to look in more detail through the needs assessment process that Orla articulated.
Yeah, I think it goes back to the original purpose of the board, in fact, of recognising that the social inequality in Somerset is a key driver around our health outcomes and all our outcomes. That we have elements of our population that are living very healthily, are doing extremely well, and we have elements of our population who are in deprivation, who do not enjoy that health, do not have those good outcomes. And I think it's absolutely critical that we got the data that provides that. Sarah.
Yeah, I just wondered, and again, I'm a bit naive about this. Obviously, one of our issues in Somerset and across the country is housing need. And I know it links a lot of these individual health needs, but I just wondered if there's a way of embodying the fact that housing is such a crucial issue for so many people and leads to so many problems, or makes problems worse, or it makes people unable to climb out of them. I don't know if there's a section I've just been looking through, I couldn't find it, but
I'll wiggle over the top of it. There you are. Yes, totally agree with you. I think
we could capture that in this, or is it not the right document? I apologise if it's not.
I think the purpose of this discussion wasn't it to absolutely say we've looked at this, but opening it up, you will see different things that we might have missed or overlooked. I think you're right. Housing is something that should be reflected at a high level in this, but actually our council data team, the housing data is very good. And I think Orla said to me that actually probably what we would do is give a front door on this to the housing challenges, but then link to the other data sources, because as you said, we don't want to replicate the wheels that are already working. But it's the front door, isn't it? It's our picture, our story for Somerset, and we have real housing challenges. So thanks.
Thank you. I've got Angela Kerr online.
Thank you. I was just going to follow through on that housing, because Somerset Home Finder has some really vital data that could tell us the number of children in families experiencing housing need or temporary accommodation. And I would a bit, as Heather's already said, I would map that in to Best Start in Life, because I think we need to watch those numbers very carefully. Increasing numbers of young children being affected by housing need and homelessness. Thank you.
Okay. Yep, Heather.
Forgive me, Bill. It's percolating through as I'm thinking about it. I think it's one of those things where, and we'll have this discussion I think later on when we're talking about a more digitally enabled system to work in. It's just that thing about we always have to be very careful about not overloading this, which has a function, with other, because there's others. Because I'm thinking, oh, we've got Transform Family View, and we've got all these. There's all sort of different things. So it's just, and I keep hearing about something that's either described as the pink wafer or fabric, which is, but I get it though. I get that. I get the entire the kind of our architecture in our council, for instance. But so we each of us, each of the partners coming here will be improving their data and their data collection, their data sharing individually. But it's like, which bits are we going to really work on, for different reasons, and be very clear. That's what I'm thinking. It's like a watchword about being clear about what we're doing and not trying to make every single system do every single thing, but to know where we go to for what information. So just very exciting times.
Okay, not seeing anybody else indicating to speak either online or in the room. So we have recommendations that the Somerset Board endorse the current approach to the production of the JSNA, and all individual organisations commit to using the JSNA to inform commissioning decisions. I'm assuming, I'm just seeing nods around the room, so I think we'll treat that as general assent. And just to echo Alison's thanks to Orla and all your team for the incredible hard work behind this, and having this data-driven approach is really valuable to that goal of being able to tackle inequalities throughout Somerset. So I really do appreciate all the work that you've done.
thank you.
Okay, thank you. Again, we move on to item 6 on our agenda, which is the NHS 10-year plan and the latest integrated care board update. The which the emphasis on the latest will be of great fascination to us all.
Thank you. Thank you, Bill. So I'm Jonathan Hickman, I'm the Chief Executive of NHS Somerset's Integrated Care Board. So I'm going to give you a bit of an update on the 10-year plan. And I think actually this segues quite nicely then into the item that follows that Alison's going to lead on around kind of what's the future of this board within the new NHS landscape that is developing. So I'm going to do two things. One is talk a little bit about the 10-year plan, but then secondly, there's an element of the 10-year plan which is a new operating model for the NHS. And so just to be kind of clear about the steps that are being taken on that, or as clear as I can be on the steps that have been taken on that. So what you've got in the pack, and what I wasn't going to do is go through necessarily slide by slide, but I'll just pull out some key points. In the pack, there's a mixture of some material that was developed nationally to support the engagement around the 10-year plan, and some material that has been developed as a result of some more bespoke and local engagement with the population within Somerset. I think the 10-year plan has been pretty well trailed in the media and elsewhere since it was published back in July. And it was a response, if you think back to the new government coming in and the review that was done by Lord Darcy, this is the response to that. So the Lord Darcy work was a kind of diagnostic of the NHS that kind of commented on where the NHS was at a point in time. This is then a 10-year plan to move the NHS into a new place. And I kind of would underline as we go through this, and particularly when we get into the point about delivery, that this is a 10-year plan. And so there are things that are starting to happen now and that will happen and the priorities for the next couple of years. But we're not going to be able to do all of this all in one go. It's a kind of marathon rather than a sprint. It was also then accompanied by the spending review, which provided the NHS with further clarity about the money, and I think actually an intent to move to 3-year financial allocations, which is helpful. We're now just about to enter a kind of planning process that I think will tell us a little bit more about the reality of that and how that kind of works itself through. So we're being asked to interpret the plan, the priority in the plan in the near term, use the information that we've got around the spending review and develop that then into a local plan for Somerset. It also, part of it, as I said, and I'll come and talk about it at the moment, it provides the context for a pretty significant reorganisation that's currently underway across the NHS, both in how it's managed and how it's governed. And I think that is a reorganisation that is touching every part of the NHS. And so I'll try and update you on kind of both of those things. But the second thing is moving quite quickly in one sense, but quite slowly in another. So maybe next slide. So again, just some of the kind of national messages. It's a 10-year plan. It's a pretty bold plan. It recognises, I think, the sustainability of the NHS on its current course is challenged, and we need to make some big changes to the way that services are delivered and the focus of the NHS as well, more towards prevention. Opportunities around technology and really starting to use technology in a different way. And that's why the last presentation actually around pulling together and having really good population level insight into what's happening, both at a kind of macro level, either that be at a county level or above, but actually really importantly at a really local level is a big enabler to this. I think there's an intent and an ambition to fundamentally change the way that we deliver care and to have a much more neighbourhood focus around care much more close to people's own homes. And you'll note in there, if we just go to the next slide, the 3 shifts. So the shifts, I think, which were pretty well trailed actually before the plan was published. So from hospital to community, analog to digital, and sickness to prevention. And I think actually when I saw the plan, I thought actually I'm really heartened by this in terms of the alignment with the Somerset strategy that we had developed and we'd signed off here in 2023. So I think there's an awful lot in terms of the journey that we started that is now being aligned with national policy, which could and should be really helpful in terms of us meeting our local ambitions. So in terms of the next, I was just going to talk a little bit about engagement, because the plan was was shaped by a pretty significant engagement exercise that went on over a number of months nationally. And in Somerset, we took a particular focus to support that. So there was engagement both with members of the public, with patients, and with the workforce and wider partners. And this, you may have seen it. There were a number of locally based engagement events through this brand of Change NHS, and that has very much gone to inform the development of the plan. It was very much focused around kind of what are the challenges that people experience through the NHS, and we'll talk a little bit about that in a moment. I think they're probably not the sort of things that anybody would be surprised about. They're the things we hear about every day. So there was a significant exercise of engagement. Over 1 million people and insights were provided back to the national team, who then had the challenge of being able to distill all of that into a sense of key messages. And I think the key themes were things like getting the care that you need when you need it, making sure that healthcare feels seamless. Actually, and at the moment, a lot of messages around the fact that you go and you have a specific interaction, but how does that actually, am I being seen as a person or as a condition when I access services? Fixing some of the basics, and then from a staff perspective, actually making the NHS feel like a good place to work, so we can retain our colleagues. The next slide goes into a little bit more detail about that in terms of the national messages that they heard when they distilled those 1 million bits of evidence back into some themes. I won't go through that in all the detail, but it's there for you to see. I think one thing that I would highlight, however, is this movement from people seeing the NHS as having a role around preventing illness and not just treating people when they get sick. And actually, that is an interesting one. And there are a whole range of views on that, I think, that are out there. But there was a kind of overwhelming move to people say, well, actually, we should be doing more around prevention, again, which I think is really aligned to what we want to do locally. From a Somerset perspective, so kind of on the next slide, we undertook an engagement exercise as part of the Change NHS process. It ran between November 24 and this March, and again we had significant feedback, which was collected through a range of different kind of media, so events, conversations, surveys. But what we did specifically was target certain groups, so children and young people, armed forces of veterans, rural communities, and Spark Somerset supported us through engagement with the voluntary sector in Somerset. And what we were really keen to do is the reason we targeted it was because we wanted to make sure that certain voices that are the voices of rural and coastal communities were as loud as we could within this engagement exercise, rather than it just be a general population engagement, which kind of then got lost, and the voice of specific communities weren't heard so loudly. So we did do general engagement, but we also targeted those specific communities within our population. And subsequently, actually, we've carried on with that engagement. So through this summer, we've included and carried on with an exercise called the Somerset Big Conversation. So we've been out across the county in lots of community-based events. I think almost 50 community-based events over the course of the summer, hearing from people about what they think about their local health service. And that's, actually some quite interesting exercises around things like, if you had the Somerset pound and you wanted to spend more money in one area, for example, what would you need to disinvest in to spend more money in that? And again, we got some really interesting views on that, and some real themes, particularly around the development of mental health services in the county. So some really valuable local feedback for us to feed into this, as well as the stuff that we kind of then fed through the national process. And you can see there on this slide, in terms of the 3 shifts, we heard some really clear messages. So people welcomed this move to having more care closer to their homes. I think that moves us very much again into the conversation that we'll have later around the development of neighbourhood health, from a health perspective, neighbourhood health working in Somerset, but the broader development of neighbourhoods. I think people recognise that there were concerns around rural transport, around community and workforce shortages, and the risk of local postcode type lotteries as a result of the fact that people can't access services. So more care closer to people's home was a definite kind of theme. I think an enthusiasm for better communication, shared records, more virtual type consultation and ways of working, more digital access. But actually, this whole point about digital exclusion also kind of being the balance to that. So we need to have a focus on including, improving digital inclusion, so that we can make sure that everybody is able to access care in a different way, in an equitable way. And then a definite strong support for early intervention, working much more around tackling some of the root causes, which is the kind of strength again of the Somerset board. But I think a reflection, something that we talk about often, about the fact that the prevention agenda takes time to deliver, and so therefore in the meantime we've got demand on services which feels overwhelming, but actually a bit of a risk that as a result of that, and as has happened in the past, funding around prevention gets deprioritised because it's not got the immediate kind of impact. So I think all of the things that we talk about really here and have been trying to deal with. I think I've covered quite a lot of the next slides. I'll just skip over that. In terms of the next shorter period of time, so I think recognising that this is a 10-year plan, nationally they've set out some ambitions about what happens in the shorter period. So this is between now and 2028, 29. So over the next 2 to 3 years, and you can see there some of the things that I would just highlight is this sort of neighbourhood health service development is very much top of the national priority, and again I think kind of working that out for us locally now. We've been working that through locally for a period of time, but actually the national support to this now gives us a really good opportunity to move it on. And linked to that, the development of neighbourhood health centres in every kind of locality. And I know we've started a number of conversations, for example, about the future of community hospitals in Somerset, and I think there's a real opportunity for us to think about that through this lens of moving more care closer to people, and the development of these neighbourhood health centres very much within people's communities. A lot of stall being put on the NHS app, so the NHS app being the sort of digital front door to the NHS, and I think we'll see some further developments of the NHS app over the next few months and years, for more access via that route. And I think actually also you'll see some of the policy announcements around prevention at a national level. So the tobacco and vapes bill, for example. I think locally, one of the things we're really focusing on is the weight loss pathway, and introduction of new weight loss medications, which could have a massive impact. But that needs to be part of an end-to-end pathway for people around kind of prevention and also lifestyle advice, etc. I'll just pause there, and maybe if I pause there and then take a bit of a reaction to that, and then I could just talk about the implications for the operating model, which is a little bit more of a kind of internal NHS thing about how do we organise ourselves to deliver this ambition.
Thank you, Jonathan. And yeah, when I read the 3 shifts at first, I thought, that sounds very familiar. It's kind of what I think what we've been doing, and almost as if they've been here, looked at what we were doing, and thought that's a good idea, and taken it away. Heather.
Thanks very much, Jonathan. Really, really interesting to hear it being expanded on, because we hear about the NHS plan, but it's quite useful. I've got a couple of bits and pieces, if I may. Just put this down so I can read my own writing here. A couple of things were around the getting the voices of people, and of course you expect me to say this now. Think about children and young people. We did just last year our children and young people's plan. We heard from 7,000 children, and for the first time ever, the children were asking, they always asked about health and well-being and mental health, but they split it out into 2 things. So they wanted leading a healthy and active life, but then also having good mental health. So one of my questions would be around, have you linked in with us about what we've heard? And I've got some others after, but have we linked in with that, and have you benefited from that information?
Yes. So yes is the answer to that. So the engagement lead at the council here has been
Yes.
absolutely part of the work that we've been doing. So the two are tied together on that sense. I think it's helpful because we are hearing the same messages. So that point about young people's mental health, I think is loud and clear. And I think one of the things we'll be doing locally then is taking those messages and thinking about how they translate into our commissioning intentions going forward.
Thank you, Chair, if I may. And yeah, and it's mental health and the physical health bit as well. So that's really important. That's lovely. I'm pleased to hear that. Really interested to see how a couple of things. I've got a few actually. Sorry about this. One is about the slide that had the concerns, what people thought were positive with the concerns. I'd really like us to hear more about how, as a system across the system, we're dealing with the concerns. I think that's really important. I think another one is about how we see the linking in with the neighbourhood work, because of course we are working on neighbourhood delivery and local delivery. So it's again that thing about how we see what's the difference between what will happen in a neighbourhood health centre as opposed to one of our family first hubs, as opposed to working collaboratively in multi-agency things. I think that would be, I'd want to see how that one works through. And I think the last one was just on that last slide, I think, or the previous slide, which was about by 2028, there would be people with complex needs will have the offer of a care plan by 2027. I thought, oh, what does that mean? Because that seemed like quite an interesting thing. And would that work for children with complex needs as well? So this is, I realise that you can, it's a massive strategy, but they're the things that I kind of fell over when you were mentioning them. Thank you.
Maybe I'll comment on a couple of things, and then there's some things maybe we could pick up afterwards on what we might cover later on. I think the point about kind of engagement and the messaging and some of the, there's a kind of yes, we agree with that, but there are some real challenges for us here in Somerset around being able to deliver this. But the bus network, the digital inclusion work, etc. Maybe there are some of those themes that actually would be really useful to talk about here, and so we could maybe just have a think about how some of that might inform our agenda kind of into the future. I wonder whether there is something about bringing the engagement report more fully back here, because we've pulled out some bits here and it's relevant to the plan, but actually there's a whole load of really good insight that's come out of the engagement and the big conversation, for example, that would be, so there's another level of granularity in here that would probably be useful for us to consider. I think we're gonna hear about neighbourhoods in a moment. I'm gonna probably make two points. One is, I think we've talked a little bit here before about there's a sort of big agenda around kind of neighbourhood mobilisation, and then there's a subset of that which is the NHS sorting itself out so that it can engage with this kind of properly. And I think we've taken an approach where we've been trying to do both in parallel. And I think that is the case. I think that from an NHS national perspective, there is now a model coming around where they think neighbourhood working from a health perspective, what it should look like. And I think we need to be able to interpret that kind of locally, because we need to have a point where top down and bottom up kind of meet each other. The point about being able to support people with complex needs, I think is a slight amplification of that, because again, when you look at some of the neighbourhood guidance that's developing, it's very much saying actually in the first element here, the NHS should be focusing on creating integrated teams, multidisciplinary teams that wrap around and support those people with complex comorbidity in the first instance. I guess largely because those are some of the people that are utilising services elsewhere at the moment, so being able to start to shift the resource around, there's an advantage in doing that. But I think we are going to see from an NHS perspective more of a sort of national neighbourhood model that's developed, and our challenge will be bringing that together with what makes sense for Somerset and local populations. But I think that probably explains the bit about complex needs.
Just one more second back, Chair, if you don't mind. That I think what's really important, and we all have this. We all have to. Everyone here will be going through in their own organisations, sorting themselves out. There's an element of that. We all have that. We have to do, and then there's the element of sorting out the system. And that thing about shared resources, shared risks, who's taking the lead on something, and making sure the solutions we create for ourselves individually have that wider look to what everybody else is doing. Otherwise, we'll sort a problem out that creates a problem somewhere else. But that's really good to know you're thinking that way.
I find this really, really interesting, and I'm really, really hopeful. I've been wanting the NHS to have a kind of 10-year plan for years, because I think you need not exactly a full stop, you can't have that, but you need a rethink of what people have come to take for granted. So what my point is this, that to me, it's about public education as well. Health is not a given. And people need to understand that it's not a given. You have to work at it. If you want to live well within your means, and I accept that some people haven't got the means to do it well, but we need to show people how to live well so that they don't become victims of our system, if you like, or come into our system. So I think it's public understanding. And since I became the lead for adult social care, my main theme has been how do we tell the public what to expect at that stage when they need our services, that it's not free for us at the moment, and how it works. I think public education is so important, and I know it has to come from the government as well. I think locally we can do stuff about that. So it's public understanding, it's how we deal with the demands and expectation. When I was in private practice, we used to call it client management. In other words, trying to persuade them not to ring you up all the time because otherwise you couldn't get any work done. So, there's a similar sort of thing of, don't keep turning up just because you think that's the way you're going to get better help. There are other ways of getting this help that you can access. Just as an aside, last night at the parish council, somebody said to me, can you ask the NHS whether corridor care has now become standard? Because I think you have corridor care nurses. And I said, well, I'm sure that's not what they want, but until we can get people to stop turning up in such numbers, or we can manage that demand, then that may have to go on. So you get asked all sorts of things at parish councils, and that was one of them. Sorry, my theme is about education of the public, because until they really understand what they can expect and what they are supposed to do, it's about rights and responsibilities, isn't it? And so I just hope that we can include some of that in how to live well and how to access services when you need it.
Thanks, Sarah. Yeah, I've recently had surgery and had a big argument with the staff that I was perfectly well to go home, and why was I occupying a bed that could have been used by somebody else? It's an interesting where that filters through the system, isn't it, Gerald?
Jonathan, I think is excellent. You may not be aware that there is an organisation that's called the Southwest Emergency Services Collaboration. So we meet regionally to see how we can work together more effectively. And a priority for us is prevention. So we met this week at the strategic level to consider, how we develop that prevention work, that joint prevention work. And one of the models we looked at was the Tri-Service Safety Officer model that's been developed in Cornwall, where you've got police, fire and the health sector employ a number of officers who engage proactively with their communities, not only in terms of reducing fire risk, also, crime risk, but particularly around the health risk. So that's where you've got one individual going into a household and looking at the complete picture, that one-stop shop. So I don't know where it is within the plan, but if somehow, and we talked about the absence of the health partners outside of Cornwall, particularly going into Devon and Somerset. So it's how can we make sure that health are actually talking with the other agencies such as ourselves on that prevention agenda, so we can have really good joined up working going forward.
Should we follow that up outside of here? Because I think we often talk, don't we, about people who are having interactions with vulnerable people in their community. So fire and rescue being one, or actually the postal service as well. People turning up every day and seeing when something changes outside somebody's house. So I think being able to make some of those connections, I think, is important. If there's a model that's in Somerset, it'd be good to hear more about it.
Indeed, and our refuse collectors also turn up to every household every week, don't they? Liz.
At the risk of sounding like Sarah, Heather and I have worked together on the script, I'm really pleased to read everything, but I'm really concerned about offer of a care plan by 2027, the ability to deliver that. The managing of expectations, and I don't understand if the number of people with a personal health budget will have doubled. What does that do to the budget for the NHS in Somerset generally?
I think the answer is we haven't worked that through. We use personal health budgets in Somerset at the moment, but for a very small proportion of the population, a small number of people. So that would be a challenge for us. to meet that kind of part of the expectation. But we just need to work it through and see this. You know, there isn't a whole heap more money in the system here to deliver all of this, as you kind of would expect. The NHS did well out of the spending review relative to other government departments, but demand is kind of going up. So this is about being able to shift resource, and it sort of segues into the bit about the operating model and how we're going to kind of try to achieve that in a way that in the past we've talked about it for a long time, but never quite managed to do it. I think I can't answer the question specifically about personal health budgets. It's in there. I think we've got to work that through in terms of the implications for Somerset.
Duncan.
Yeah, I was just going to add on. So Peter and myself and Ruth from the GPSU are commissioning a small piece of work as well, just to actually bring together some views that we can then all discuss about what this might physically look like in Somerset, because there's a huge amount in the 10-year plan, as you can see, and actually we could start picking each individual aspect of it and do something and go, did that add up to what we wanted it to look like? So there's something about, if this is a top-down vision about how the NHS works from the national level, what's the bottom-up vision from Somerset in our case about what we want it to look like? So we've got a quick piece of work. We've hired an organisation called the National Association of Primary Care. Got that right? Because actually a lot of this is about GPs and how we work with GPs, and how lots of the things in here about, you know, neighbourhood health services and stuff that's not on the slides, but is there very clearly about GP contracts, form of GP contracts in the future, etc. It's all in there. So what we said is, you know, if we come up with a vision for Somerset, not saying that's it, but a vision we can then all discuss and say, is that what we want? We need something to start with, a starting document that says, you know, how do we think it should work in our communities in the future? How does it say, actually, that physical approach, we can call it that, does tie up all the things in the 10-year plan, or it ties up these things in the 10-year plan, but these things then still need someone else to look at? And how do we make sure that we're actually taking a lot of partners with us? Because I think, as Gerald was saying, yeah, there are lots of really good initiatives out there. You know, we're having good conversations between the ICB and the council about what neighbourhood working might look at in the future outside of that. If we make everything one big thing, it's probably too big to do anything with. If we make everything one individual thing, and there's thousands of them, there's too many for us to manage. So at some point we need to say, look, we're carrying these ambitions through this, what does a community look like conversation, and these other ambitions we're dealing with differently. So that's literally just starting that piece of work. It's not going to be a long piece of work. It's going to be hopefully a couple of months. And then we should have something that we can actually bring back to this board and talk to lots of other partners about, saying, if this is a starter for 10, how do we want to change it, improve it, or what do we want it to look like differently? But we just need to get that conversation going. I'm very conscious as well with new ICB clustering arrangements. If we're not careful, we could run into a position that says, well, here's a national view, here's a cluster view, and everyone's still going, and what's the Somerset view? So we just need to do something to get a physical mapping there that says that's what we think success would be.
Shall I talk a little bit about the implications for the NHS operating model? Because that's the sort of second element of this.
I think that's where we're going next.
Yeah,
I would think
it feels like that's kind of like that we're naturally kind of leading there. So again, there's a couple of slides in here around the operating model for the NHS. I think there's a fairly fundamental change going on in the NHS, which probably people outside the NHS may not see. And it is a kind of, it's root and branch. So it's starting kind of at the top with at a sort of national level with the coming together of NHS England and the Department of Health and Social Care. So a big change process at a national level, a big change process at a regional level, where the regional kind of office, if you like, of the NHS is being redesigned and refocused. And I think in a way, for some of the people who've kind of been around the NHS on a few iterations, I think a return back to the regional office having a much more active role in performance management directly of trusts and kind of improvement kind of type of activity on the basis of that, but also holding kind of commissioners to account, so the new ICBs to account for their commissioning activity as well. A big change in ICBs, and I'll talk a little bit about that in a moment, but also actually some fairly fundamental change in providers as well, both in the short term in terms of trying to square the kind of financial challenge that we've got and the growth in workforce that has happened over a period of time, but actually fundamentally some changes around and some language that at the moment I think we're not quite clear what it all means. So things like the development of neighbourhood health providers, which is a very neighbourhood health providers, which is a very big policy move, but it's not really quite clear what they are and how they work. And as Duncan was saying, I think how the contracts, the existing contracts for general practice and primary care work through them. And the development of integrated healthcare organisations at a local level. And I think actually Somerset's in a really good place to be a forerunner with that, given the work that's happened here. But I think our lens in Somerset is not typical across the rest of the country, and most of the rest of the country is not in a place, I don't think, where it will be able to be at the forefront of that. That's going to take time to develop. From an ICB perspective, so we've just this week had published something called the Model Region, which sets out the role of the regional office of the NHS within all of it. That was a big thing that was missing because we didn't really know quite what they were doing. I think it is a little bit clearer, but as with all of these things, you get a bit of clarity and then it raises a whole heap more questions. But that sort of move to kind of more of a regulatory oversight, and as a result of that, focus around kind of performance improvement is definitely the direction of travel for the region. For ICBs, the intent is that the ICB moves to become something that's being termed strategic commissioning. Again, I think there's a whole load of nice diagrams that show what strategic commissioning might look like in the future, but some real detail to work through in terms of what that means. I think for example, the conversation that we're going to have towards the end of the agenda today, and the one around the JSNA, is hugely important, because that joined up linked data set has to really drive commissioning decisions in a way in the future that it hasn't in the past. And I think what the expectation of the ICBs is that we move to a point where we are able to commission this shift to neighbourhood health in a way that hasn't happened before through the contractual levers that we've got. Now that definitely gives us some challenges around where the money is currently sitting within the system and how we shift that money to be able to support the ambition around neighbourhood health. In parallel to that, the ICBs have been asked to reduce their running costs, so their overall running costs, by 50%. So that's a significant kind of ask. And what that's also moved us to is a point where we've then started to look at ICB geographies and clusters. And I think, again, that's sort of been the work of the last few months, and it's probably well known, but Somerset is coming together with Dorset and then Wiltshire, Swindon and Bath and North East Somerset. So a pretty big geography now that covers the kind of Wessex part of Somerset and of the country. And part of the thought process around that was kind of an alignment around future strategic authorities. So that's in there as well, although it doesn't work kind of neatly. There's a couple of geographies where there's still some things to be worked through. But from an NHS perspective, the pragmatic approach was to take BSW ICB, Dorset ICB, and Somerset and bring us together. So that cluster's been agreed. It's a clustering model, not a full merger at this point in time, because I think moving to merger locks some stuff down when actually there's still some conversations around the geography to be had. You might also have seen that we have made an announcement around the chair of that. So the chair appointment has been made, Rob Whiteman, and the chief exec appointment the process is just being concluded, and an announcement will be made shortly. But we will then be focused on bringing together three organisations into one, and reducing our headcount and our operating running costs by 50%. So that's a pretty significant challenge for us. And there's a risk, therefore, that we look down and into the organisation and just spend the next 12 months doing organisational change, which is I think a bit of an inevitability, but we've got to balance that with moving forward this agenda. I think the other two things just to mention, one was the move in the alignment with strategic authorities and mayors, and I know there's still a lot of politics to run on that one as we sit here today. And I think actually also a move to more earned autonomy by providers, so providers being able to work again for folk that have been in the NHS for a while. When the foundation trusts were originally set up, there was a whole heap of freedoms that foundation trusts had, particularly around kind of investment of surplus and different ways and different rules around kind of capital investment that over a period of time have changed. And I think there's a desire to kind of move back to some of that. But with that, earned autonomy becomes a kind of a greater reliance on and focus on accountability. So being able to balance those two. And I think we also will start to see, as I said, the development of integrated health organisations. So organisations that take a wider view of health and services in their population, and over time, actually, the ICB being able to delegate certain elements of commissioning to those IHOs. As I said, I think Somerset. So I think the reality will be there will be a small number of them in the short term, but I think Somerset's really well placed to be one of those if that's what we decide is the right way forward. But it won't. That's not kind of like a big thing that's going to just happen overnight everywhere. I think because different systems are in vastly different places to deliver that. There are also some implications on here for the future of integrated care partnerships, and I think one of the things I would say is I think as we've started to think from an ICB perspective about how the new cluster will work, which effectively will cover 6 council boundaries. So Somerset, Dorset, Christchurch, Bournemouth, Wiltshire, Baines, and Swindon. So 6 geographies. The importance, as we've talked about, about maintaining kind of those local relationships and that local partnership arrangement is huge in terms of our operating model. This cannot just exist where we have this one ICB that's trying to sort of manage the whole thing from I think Frome is probably the geographical centre, but from an office in Frome or wherever it is we end up. But I think so the place-based partnership is really important, and I think there's a conversation for us to have then about how this board actually actually holds a lot of that. And that's the kind of conversation that Alison wanted to kind of open, I think, in her item. But I think we're really well placed here actually with the Health and Wellbeing Board and the ICP together for this to be a really strong place-based board, if that's the direction of travel that we agree, and that has a really strong kind of voice into the new ICB. So there's definitely some thought for us to give here, and there might be other views that are out there. So I think the headline is there's quite a lot of reorganisation going on in the NHS quietly behind the scenes. That does risk us being slightly self-focused for a period of time, and actually also really quite practically focused, because where folk are leaving, for example, we're not filling vacancies. So I think there's a short-term thing about how do we deliver on all of the things that we said we are going to deliver on. The final point that I would make is that whilst all of this conversation is happening, nothing changes until there's new legislation, which is not currently kind of there. So the statement about the intention is to abolish integrated care partnerships, none of that happens until there is a legislatory change, which is definitely not on the cards this year. So there's an element about us needing to keep going, doing what we're doing, but being mindful to what that future looks like. I'll probably stop there. I'm sure that's created a reaction. I get that sense around the room.
And just to add to the excitement, the changes in personnel at MHCLG and all the other things we're reorganising in local government at the moment, which it's we business as usual is distracted from, and trying to actually implement a 10-year plan is distracted by let's reorganise everything. Gerald.
I promise I'll be quick. With all your change, and you mentioned MHCLG, I'm going to just champion the local resilience forums. There is currently a real existential risk to the funding of those through the reduction of health partners as Cat 1 responders. So could I just make a plea for the LRFs?
There are a number of things that are at a really practical level are being thought through after the announcement's been made. So the LRF element is one. There's a whole heap of other things like safeguarding, for example, continuing healthcare, infection prevention control, etc. And I think there is a movement and a recognition actually that you know, the ICB's role in this is still an important thing. So we need to work all of that through. Yeah, I know there's really active conversations going on around emergency response and the LRF.
Thank you, Heather.
Thank you. Just to say, I think we do need some, not quite business as usual, but I think in the short term, we probably need to keep this group working at its optimum and possibly better than we have been doing, but certainly at its optimum to make sure we're all working together well. It makes me feel a bit twitchy, the description of that very strategic mayor, you know, regional level being responsible in a sense, or good, they're responsible, being the only thing that's been mandated. It makes me a little bit twitchy. So we can, but doesn't mean say we can't keep doing what we're doing, but I think it makes what we're doing even more important. Otherwise that strategic kind of, or that advantage you can see that we have would be squandered.
Yeah.
So I think that's really important to keep going.
Just going to comment on that because we've started conversations with the 6 councils, so with the chief execs, but also with the leaders. And I think, you know, I think there's a really good conversation for us to have about how we bring all this together, but how we do the right thing locally.
Forgive me, Bill, for being rude, but it's not a coterminous thing though, is it? Because the current strategic mayorally authority doesn't quite fit. But not for the first time I'm saying it doesn't quite fit. These things don't quite fit, do they?
Indeed, we have the Baines and the Swindon issues to resolve, and I'm reminded of, I can't remember the quote from Bismarck about the Schleswig-Holstein question, but yeah, we are in a very, very bizarre situation, and but also very aware to our colleagues in local government and in public service to our west, and the difficulties that Devon and Cornwall are facing as they move towards LGR and one system, and the sensibilities there. Duncan.
Yeah, I was just going to pick on a couple of points. I think I'm more comfortable than Heather is maybe on the strategic mayor and that role, because I think what we need to see in the ICB cluster around the final footprint when it's legislated for is actually these really strong place-based arrangements, as you were talking about. And I think that gives the ability almost of a regional mayor to be able to say, it's not working as well as it should. What are you all doing? There's something about that check and balance to me that in the current system's a little bit missed. Everyone's in the system. So I'm not sure anyone's stepping back and saying, actually, are we really reducing inequality? Are people in these difficult communities really getting a better deal out of it? So I think if we make it work, we can make it work, but we'll have to make it work. And that'll be the key thing. What I was just going to, I can never remember what it was either, but the question about boundaries, allegedly, they will sort out the boundaries when the cluster will reflect the MSA. But at this point in time, there's no timetable for the mayoral strategic authority either. So at this point in time, there's a huge amount of legislation government stacking up that might never get to. But the key thing I just wanted to see if Jonathan could comment on, what's the current thinking about delegation of commissioning function? Because I think most of us would think it would be a lost opportunity if all that happened is the current ICB did everything it does now, but bigger. And, you know, there is an obvious opportunity of doing that, just trying to maximise the size of the ICB at the cluster level, keep as much of a function there. Whereas actually, I think for some things we want to talk about on place base, I'd be really interested, for example, in commissioning of GP practices and so on and how that's done, because we've got a real interest in how that works in the future and how it runs. And if we're an integrated health organisation, or if there is one in Somerset, that would again change the commissioning arrangement. So I don't know if you can say anything about that.
Yes and no. I probably can't go too far with it. I think what we so the idea of starting to bring together and have an arrangement by which we can delegate, I think is probably where we are now. Certainly from an operating model perspective for the new ICB, what we're thinking about is how do we make sure that so there's some things that on day one we'll just need to carry on doing. So GP commissioning is one example. So you could have a hub and spoke type arrangement where you have some sort of policy at a cluster level, but actually the delivery and the relationships at a local level are really important. You know, we've definitely seen that not just through general practice, but some of the progress that we are starting to make, and there's a lot further to go around kind of dentistry, for example. But the progress you make is because you've got relationships locally, and you start to identify opportunity as a result of those conversations. So I think we're thinking about a model that enables us to do that at the point at which then IHOs are up and running, and we can then talk about delegation. I think we would still maintain accountability, but we can delegate the kind of function of it. But again, I think that if you look at that across the 6 geographies, it'll happen at different paces in different places depending on who's ready for what. So we sort of got to have a kind of target model that enables us to do that and hold the ring on it, but at the same time be ready when stuff starts to develop locally. That's the sort of mindset. We haven't had a specific conversation about what, when, and how. And I think in a way the work that you alluded to around the kind of provider element of this, and us making sure that we've got a really strong place-based arrangement here in Somerset is the precursor to enable some of that to happen.
Can I come back briefly? Just I think thank you, because that's really helpful to know. I suppose my concern would be if all the staff in the new ICB physically are in a commissioning function at a cluster level, there is going to be no appetite in 2 years' time to start transferring people around different bits of a system after all the change we're going through now. So I just think when we start out, there needs to be a really clear vision about, is this about a thin commissioning layer with other people who are in the commissioning layer, quite rightly, as you say, because to start with, they've got to be, but with the view of not necessarily physical delegation of staff, but the view that they are actually about place-based commissioning rather than cluster-based commissioning. Because I think that will be really difficult to unpick as a organisational culture afterwards.
Definitely, and so that is front and centre of our thinking. So so when you start to think about what does a new organisation do, it's got some delivery functions that we need to right size and then may transfer elsewhere as time goes on. It's got a kind of corporate element to it. It's got this whole thing about strategic commissioning, which is we do that once actually across the cluster. That's the sort of mechanics of it. But actually, it's important that we then face into local geographies and that the locals. So working out what goes on at a place level is a really important conversation for us to have now. And I think we're also recognising that what we don't want to do as an organisation is to be in a world where we're forever reorganising. So if there are changes to boundaries, actually being able to say this is what this is the place-based arrangement that happens in that place. These are the folk within the ICB that are working there, and then they transfer somewhere else as time goes by. It won't be perfect, but to be able to have that as our sort of overarching set of principles is definitely where we're thinking.
Brilliant, thank you.
Sorry, I just want to close something out at the same time, and it's the boring message that also needs to be heard, which is that much of the ambition that we have and so on has still to be earned, in the sense that the first and the greatest priority is that we deliver this year to our plan. And if we are distracted from doing that, then we will have the right to achieve much of this taken away from us. So we cannot leap ahead without completing the task in hand. And it's really important that everybody recognises that that effort is as important, if not more important, than the next step.
Okay, I'm not seeing anybody else wanting to contribute on this agenda item. There are no recommendations attached to this other than notes. It was information and update.
It was a briefing, and I would say within the slide pack, there's a whole heap of detail that follows on as an appendix, which is kind of more condition specific in terms of some of the thoughts from the plan. But obviously, I've not gone into the detail of all of that today. But it's there for you to review.
Okay, thank you very much. So we move on to agenda item 7, which is the implications of the NHS 10-year plan for Somerset Board ways of working. And Alison's going to lead on this.
Good morning, everyone. So my name is Alison Bell. I'm the Director of Public Health for Somerset Council. So I just wanted to follow on from Jonathan's update about the NHS plan, really. And I think the discussion to date recognises that it gives us plenty of exciting opportunities, some risks as well. It is badged as an NHS plan, but it reaches into the work that we've committed as a board to do to improve the well-being of our population, but also address the wider determinants of health and also to tackle the pervasive inequalities that blight people's lives. So we know it's only through our collective action that we strengthen families, we strengthen our communities, we make sure people have houses to live in, and we make sure people have work and are economically productive. So it is an NHS plan, but the work of this board is so much more than this. And I think we have to acknowledge that. But this presentation is really to say, well, to realise that we need to get organised and we need to have a clear vision about what we want to achieve and how we want to work together effectively. So what I'm just going to talk through very quickly, there's an orange waiting for all of you in the kitchen, is the implications of the NHS 10-year plan and what that means for the Somerset Board ways of working. I'd just like to say one thing though before I start. I'd like to acknowledge that there's people in the room that don't know their place yet and their role in the future system, and that must feel a bit uncomfortable, and we should just mention that and pay testament to them still trying to do the best they can for Somerset every day. Right, thanks to Rish and Chris for doing the slides. Next slide, please. So the purpose of the slides are to lay out the current understanding as the legislative impact of the NHS 10-year plan and what that will mean for the Somerset Board and its governance. These slides don't cover at all the work that we need to do to align our Somerset Improving Lives strategy with the NHS 10-year plan. It is just focused on the governance and the structural changes that we think are signalled. But we shouldn't forget that governance is an enabler, and that's how we will improve outcomes, and we can only achieve those together. So that's why we're having this conversation, not as a council, but as a partnership about what governance we need going forwards to achieve improved outcomes. Next slide. You'll be delighted to know that I'm not going to take you through the detail of this. This is us at the moment. Okay, I'm sure you all know that. So we're a Somerset Board, we're a committee in common, and we deliver the two functions of the Health and Wellbeing Board and the Integrated Care Partnership. That's all I'm going to say. This is the future. Next slide. As we see it, in that, as Jonathan signalled, we won't be required to have an integrated care partnership, but that requires a change in legislation to be decided on timescales. So as Paul articulated, we need to carry on. We need to deliver for this year, and we need to still have an integrated care partnership until we're told differently. I remembered the next slide, please. I remembered the name of the politician who talked about known and unknowns. Do you remember Donald Rumsfeld? Yeah, I don't want to be compared with him, but the knowns and the unknowns. So we know the integrated care partnership will be ceased, but we don't know the timeline. In terms of the Health and Wellbeing Board duties and status, the Health and Wellbeing Board will remain a statutory committee of Somerset Council, but it's likely that more duties will be added, particularly around the Better Care Fund, but also around neighbourhood health plans. And what I've read in the NHS plan is our Somerset neighbourhood health plan will be utilised to inform the strategic commissioning objectives. So I know what I think I heard in the room was some nervousness about the remoteness of commissioning, but we will be writing the plan. We will hold that, we will share that responsibility to inform commissioning. So that will be a lot of work, but really important to do. The unknowns are, as Jonathan articulated, the impact of the changes to the function of the ICB. And I haven't seen the model region functions, but we've got these gaps in function that we don't know yet where they're going to be held. And Gerald mentioned about emergency planning. Next week, we're doing a pandemic flu plan, a pandemic plan test, and we're not really sure what that's going to look like in the future. But anyway, detail. Another unknown is we don't really know how many neighbourhood health plans we are going to have. Is it a Somerset one? Is it sub-Somerset? So these are the details that we need to work through. And I think a really important part is the membership of what a future partnership will look like. I'm a fairly new member to this partnership, but I'm really impressed that people play such an active part. And we hear voices from so many different parts of the system, and that is vital to preserve, because as I think our colleagues from Citizens Advice said, you know, we can't achieve things unless people are living in decent homes. So we have to preserve that relationship and that membership to make sure we really reach into wider determinants, not just what happens in a GP surgery or a hospital. I think it does give us an opportunity to look at broader membership and really be a bit creative and innovative. And Gerald, I think we'll all be lining up to talk to you about your preventative work at coffee time, because that sounded really exciting to learn from Cornwall. So, next slide. There are a few risks. Coming back to what Paul said, you know, we have to deliver the plan this year, and there's so much change. So that's kind of the biggest risk, because what I heard from you is we have to earn that autonomy. We have to earn the right to be an integrated health organisation. So we've really got to focus on delivery this year. We're going to lose staff, people that we've worked with system knowledge and valuable skills. We know, or we're concerned that we will lose the focus on Somerset, and we're a bit concerned that the Health and Wellbeing Board's functions might be lost. But there are lots of opportunities, and I'm not going to go through those because I think many of them have been articulated. We're just waiting for more of the national guidance, but I think it's really important in all those plans and structures that come down, we don't lose the opportunity to shape what our place-based partnership can be and does deliver for our population, because we know our population best and we know what's been working really well. So we have to get ahead of the game. I think, like Duncan was saying, have that vision for Somerset. And if what is sent down to us we don't think will work, I think we'll have to be brave and stand up and say, that's not going to work for us, actually, we need to change it. And maybe do that as early as possible. So these slides are based on a discussion internally. We might have forgotten things or not thought of things, but our proposal to the board is that the NHS 10-year plan doesn't signal a legal date for the changes it expects. So we believe that the Somerset board should continue to operate as it is until March 31st, 2026. But we think we should try and get ahead of some of the changes, and we're proposing a small working group is established to fully review all of the things that are coming out nationally and make a proposal back to this board in November about how we should respond to that guidance. And we'd prefer not to do that in isolation as a council. We'd prefer to do that with partners engaged in that process, because it will be better if we work like that. And I think it's important to say that we will communicate agreement with this approach out to all partners, not just those that are present today, to make sure they're signed up to our way of evolving how we work. And I think it's important to note that this board is a committee of the council, so we will be required to take any changes that we come up with through the council's Constitution and Governance Committee, of which Alan is my boss, is our representative. So I think the question I have and we have is, are there other considerations that people think we are missing? And are you in agreement with the approach to set up a small working group to scope some of the documents that are coming out and come back with a way of working in November? Is that okay, Bill?
Absolutely. Do any suggestions as to who should be on this working group?
We do like volunteer. So, you know, I don't think the door's shut to anyone, but I think making it small is probably a good idea. We don't want to replicate this board and have everyone's views. So maybe, you know, voluntary sector, maybe an NHS voice, maybe a council voice as a starter for 10, but we're not shutting the door to anyone that would, you know, want to be a part of that.
Duncan?
Yeah, I wasn't volunteering. I think I'll be fighting colleagues off if I volunteered for the council seat, and I wouldn't want to do that. I was just going to say, I think happy with the proposal, but I think we just need to accept that we need to keep looking at the membership over probably the next year or so, because I think however the ICB cluster develops and however the 10-year plan comes out, for example, I always feel we're quite light in this group with GPs and GP representatives. That's going to be really important if we're taking on as well a place-based type role, working within a place arrangement within the ICB cluster.
Yeah, absolutely, and also very aware that the ambulance trust is rarely seen and never heard in this context, and I think could add so much, and also other elements of primary care as well as GP. Yeah.
Just a sort of couple of points. I think so. The first one around the board continues to operate until 31st of March 2026. That feels like a bit of a hard stop, and I think the reality is that it will carry on until the legislation changes. It probably is the reality, because I think sometimes you put a hard stop against something, then people expect that something's going to happen on the 1st of April, which is probably unlikely. So I think it's probably an evolution, isn't it, of this board, and the completely the idea of having a working group who get their heads around how that might happen. The thing, so I think again from an ICB cluster perspective, just reiterating the point about the importance of place-based partnerships within that, and I think you know, there are arrangements in place that are sort of similar but a bit different across all of the 6 council areas. So we'd want to make sure that we had a way of being able to interface which was as far as possible consistent, but that also make sure that it had local element on it. So I think there probably is a connection for the proposal back into the ICB cluster, just so that we can make sure that we kind of see how that all fits together with what's emerging and developing elsewhere, so that we're able to properly engage with it.
Okay, I've got Judith Goodchild next, and then I'll come back to Alison.
Hello, Bill. I'd just like to say about Healthwatch. Healthwatch is actually fully funded until the end of this financial year, and the chances are it will probably be funded for the following year. There's until the legislation changes to the statutory requirement, then we will continue to be an independent body. There is an expectation that our function will be supported in the future by the Somerset Council and the Integrated Care Board. And that is my understanding currently of what the situation is. So at the moment it's business as usual, and really I think we should be fully involved in any discussions that are going on about the ways forward.
Yeah, thank you, Judith. Alison?
Yeah, thank you. So that sounded like a volunteer, Judith. Thank you. And just picking up Jonathan's point, so I think that's a good suggestion about the 31st of March. Change that to until legislation changes. Sounds like the voice of experience. It sounds like we're suggesting as soon as the ICB cluster staffing is a bit more formalised, that we start building a connection with that, so that we make sure that, as Duncan suggested, we evolve the membership of this board as we go over the course of this year. Is that understanding? Excellent. Thank you.
I think that that's really important, because I suspect that there is learning to be had, because certainly within the cluster there have been the challenges of having place within the system, as it were, and it's worked. They've pulled people together, not always easy, but they've achieved some things. So there will be information for us there. So maybe your working group needs to draw that in.
Yeah, thanks, Paul. And I've certainly connected to the other directors of public health in the cluster, and am aware of the BSW arrangements, Baines, Swindon and Wiltshire arrangements. So have that in my mind as well. Thank you.
Just one other point. As you said, it would probably come out through the working group, but it's just to kind of raise it really. But I think when you think about the ICB cluster and the current kind of formation of the board, at the moment we've got kind of partner members on the board from a number of different areas. If you think about that at a cluster level, it's going to be really difficult for us to have 6 representatives from 6 councils and all of the providers, and we'll end up with a board of kind of 40 people or so, which will be a bit unwieldy. So I guess there's an opportunity actually to connect the voice of Somerset and of each one of those kind of partnership areas, and we're just starting to think that through into that board, but in quite a different way. So I'd be really interested to have the conversation about let's do what you're saying, Alison, in terms of coming up with a plan around how this board evolves into that sort of partnership board. But then what is the interaction between this partnership board and the ICB board? Because I think we need to make that as neat, tidy as we can to make sure a voice is heard. The voice of Somerset is there as well. But there's a challenge in that, and having a board that is so massive that it's not able to make any decisions. So that it would be good. We haven't made any decisions on that basis, but it would be really good to inform that thinking in both directions.
Okay.
Yeah, I think just on that point, I mean, I think lazy logic, but I'd been assuming there'd be some sort of place board at the cluster level, which all of these local place boards would report into in some way, and that would represent the place back to the main board. I don't think there's a consensus view, but there is definitely not a consensus view amongst councils in the cluster about what the arrangement should look like. And I think there are some people thinking, because they're on a board now, they'll still be on a board in the future. We just need to agree that's not tenable. So I think as soon as the chief exec can be appointed and we can actually make some view about the size and shape of the board of the cluster, that starts to drive some better thinking. Because right now, I'm not seeing people jockeying for position, but I think there's a lazy logic of I'll still be where I am now. And that's not tenable. We can't have a board, as you said, at that size.
Okay, not seeing anybody else indicating. So we've got recommendations before us to continue to operate as is. Jonathan's point to remove the date, I think, is pertinent, because who knows? And a small working group is established to fully review and recommend any changes for agreement at the November the 25th board meeting in relation to the operation of the board. My reading is that you want that to be established at the November the 25th meeting, or established now and report to the November the 25th. That's okay. That it's slightly read it slightly ambiguously. So volunteers. We will find some volunteers. Yes, we will inflict suitable pain. In fact, we just volunteer everybody who's not here. That's usually the good approach. And recommendation 3, the approach agreed will be communicated to partners to clarify the board's position following the release of the NHS 10-year plan. Are we all content with those recommendations? Good. I'm going to propose that we take a comfort break now, as we're going for an hour and 45, and then resume at midday. Is that okay, everybody? Okay, thank you. Okay, welcome back to part 2 of our Somerset board meeting, and we're moving on to agenda item 8, which is the improving live strategy stock take, and Rizard's going to present, please.
Thank you, Chair. Good morning, everyone. So this was a piece of work that was sort of discussed primarily at the workshop that we had, where we said we'd like to take just a bit of a stock take for the improving life strategy, see where it was, and sort of how relevant it is currently still in that regard, but also what the linkages are. Primarily because obviously all the system changes that we've heard are going on, but also for the fact that it is coming to its end of life in terms of the agreed dates at the time of being 2028. Button doesn't move on the slide, bear with me a second. So the purpose of this presentation really is to flag that it was written back in 2017, 2018, the Improving Life Strategy, and it is what we would call our joint local health and wellbeing strategy. That's what they call it most of the time in other health and wellbeing boards. We've named it the Improving Life Strategy to probably make it a little bit more accessible in that regard. We originally was written and with a very much an intent that other boards and partnerships delivered the strategy, and we're responsible for the delivery of that strategy. But over time, the nature of those boards, the names of the boards, the membership of those panels and partnerships have shifted. And so that's what this document aims to do, is almost recognise the fact that as time has moved on, those partnerships and boards might not be in place anymore, moved in some way, and to almost reconnect with the delivery branch really of the Improving Life Strategy in that regard. So just some quick background on it. So again, it was about galvanizing local partners, organizations towards the common goal that was set out in the strategy, and setting those 4 key priorities as laid out. And really about health and wellbeing boards still need to decide that they are assured that the change is happening and that we are still responsible for those plans. As been previously mentioned, there will be neighbourhood health plans coming in as well that we'll need to tie in that Improving Life Strategy to at that point as well. Establishing the priorities. These are the priorities of the Improving Life Strategy with 2 ambitions at the top there. I won't read them out, but ultimately they broke into 4 main areas around the priorities about infrastructure and productivity, safe, balanced communities, fairer life chances for all, and improving health and well-being, really. So there were sort of 4 main strategic priorities established, and at the time that was backed by the GSNA. It's not meant that those 4 things cover everything that we could cover off, because it'd almost be an infinite strategy if it tried to cover everything that everybody around the table would be interested in talking about. But these were the 4 main drivers we certainly needed to see in Somerset in reflecting what the JSNA has told us at the time. So back then in the original plan, this is a table that sort of is laid out that shows those 4 key priorities down the left hand side. Then the lead partnership that was in place at the time or was going to be established to take care of that priority area and lead on it and be responsible for improvement in that area, and any related strategies or plans that were again at the time already in place or that were planned to come into fruition soon. What I found through meeting with various members of the council and other areas is that a number of these boards either have changed their name now, or for example, the Stronger Communities Board actually never got underway, never was convened in any way. Sort of because I should flag as well actually the history of this. Obviously, this was written in 2018. We hit 2019, and then something quite drastic called COVID happened, which sort of kiboshed quite a lot of the planning early on, certainly in the public health sphere. Of what work would be done on this. So to some degree, that's partially why some of this work wasn't taking place. I'll put that caveat in there. A number of this is also just the natural movement of work over time, the natural shifting in priorities and understanding of how we need to organise ourselves in terms of partnerships and things like that. But we don't have things like a community strategy. We don't actually have a Somerset housing strategy currently. And obviously there's a few strategies in here now that have either come to the end of their life or coming to the end of their life as planned soon. So what I've done again is I've sort of gone around, talked to a number of officers, identified where those links could be re-established to lead partnerships and lead boards, and what their current strategies are, or where they intend to shortly release a strategy, and also where there's the opportunity for they may be renewing a strategy soon, and Somerset Board could take a part in influencing what their strategy will be coming out. And actually, this is again ties nicely into the conversation we were having earlier about the need to sort of coalesce as partners and make sure we're all heading in the same direction, not only on a structural governance level, but also within our key strategies and policy documents as well. So that's really what this slide is starting to really start to lay out for the board, is where I think, I suppose, from my perspective, more further work could be done to connect to these groups, connect to these boards, ask the board today whether there's any missing that we'd like to be seen. Again, we don't necessarily want to have every single partnership board listed possible in this area, but almost that there's an agreement that yes, these represent good lead partnerships for the Somerset board to connect with, both on a reporting level, but also just on a, what are you discussing at your board meetings? Would Somerset board be interested in the conversation that you're having, and vice versa, and linkages as previously mentioned. So if I can, Chair, I'll pause there for a second for people to reflect on that, and then the next few slides in the pack just really lay out those 4 areas in a broader term, really.
And Heather first.
You're a bit sick of me talking. I do apologise. I think it's great to see. It's lovely to see that progression through from what we had to what we, what you've identified now. There's just a couple of things that occurred to me, and there's probably more. But a couple of things immediately occurred to me were some of the meetings and conversations I've been having recently. There are things like Somerset's own, Somerset councils, I should say, own planning and licensing policies are really important because they are there are opportunities to nudge health. And I think the other one is the local plan that we're working on. So we have both built environment for things like safety and so on and life chances, but you also have that thing about the infrastructure that's going in to the local plan, how that supports what's happening elsewhere. I'm not going to try and drop anything on Richard, but I just wanted to make sure, because Richard's in the board with me here today, if there's anything on the children's side that I kind of missed. But I'm just thinking, I think we've got the right ones in there, but there might be some other things that I might have missed that you may think of. So sorry to drop that one on you.
Yep. And just a slight extension to Heather's comment that yes, we have the Somerset local plan, but not all of Somerset is covered by that local plan. We also have the Exmoor National Park area, and we do need to influence that as well because of the rurality and the hidden deprivation that's in that area as well. Any other comments, Richard?
Yeah, thank you. I'll pick up on Heather's point around the children's side. I think we're really focused at the moment on kind of what's the future, how do we need to transform and work really closely together, particularly through neighbourhoods, and considering at the moment whether maybe shifting the joint conversation, the partnership conversation into a transformation space might be helpful. So we've got a transformation board that's independently managed, and maybe kind of having the conversations there where we really focus on the practicalities of what we need to put in place, and how that will affect us working together well across the whole system might be the right shift. So just to note, there may be a bit of a shift in how we're sort of running that partnership and then reporting through to here.
Alison and Sarah, then Alan.
Yeah, thanks very much, Rich. This is really helpful. It feels like a bit of a reset, doesn't it, of just clarifying that we've got objectives in our improving lives strategy. We've got delivery partnerships that should be delivering against those objectives. And then my understanding is the relationship is then we can be used to unblock things that those partnerships can't resolve themselves. So we're almost like a point of escalation if those individual partnerships can't deliver. Is that correct? Because I think it's a time where we need to kind of push forward things like housing, homelessness, and unless we're really explicit about the relationship between those lead partnerships, their strategies, and this board, we're not going to move things forward, and I really think we need to.
Just to mention, I'm not sure if it needs going on here, but we also have something called the Working Together Board, which is the co-production board with care experienced people in it, and it's really valuable for the insights they give us into what we're providing. I don't know, as I say, whether it needs to go in here. I just wanted to mention it because it's a really good board that we've got working now with care experienced people. Thank you.
Thank you, Chair. I think to follow Alison's point in particular regarding the previous item and then linking through into this item as well around the focus and the strategies that are feeding through, I think unfortunately we've got the start reminder of the Blackpool CQC report, which gives us some really helpful indicators about the importance of ensuring that the strategies, the working groups and the activities are feeding into and delivering the broader objectives of the health and wellbeing strategy. So I think there's an opportunity here to kind of review and refresh, make sure these groups, these strategies are the right ones, that we're kind of getting the right feedback, and then I'd argue reconnecting all the linkages back to these boards so that this board has got that kind of oversight and kind of grip associated with it. But there was a stark statement in the CQC about the Health and Wellbeing Board in Blackpool not having impact and not having the right and also not maintaining attendance from senior leaders because it wasn't having impact. We don't have that problem in Somerset, but what we do need is to make sure we're reconnecting it so it continues to remain relevant. So I think, my apologies, Chair, I think it's just a start reminder of how important it can look and feel like a stock take. It can look and feel like a tidy up exercise, but it's critical in terms of how external parties are going to assess the Somerset partnership. So I think it's just that reminder of we do need to get that working group underway. We do need to make sure we've got that ability to map all this through. Thank you.
Thank you. Well made point. I also just wonder on the cross-cutting housing point as well, whether the home finder policy could also sit under that as well. Any other comments or suggestions, observations, reflections, cogitations? Alison.
Yes, sorry, just another thought. So how historically as a board have we been assured that progress is being made in these delivery partnerships? I'm not suggesting we have endless reports. Do we operate on trust, or do we have a dashboard, or how have we worked, or how should we work to make sure we're on track?
So I can't speak to historically, obviously being new to the board in that regard, but I think it was a bit word of mouth to some degree, probably also seeing some annual reports historically as well for some of these areas. But as we saw, a number of them weren't actually set up or convening in that way. Certainly moving forward, my proposals in the latest slide is that as part of the Somerset dashboard that I bring to this board and its ownership, it lifts out some key metrics and measures or priority areas that each of these strategies are aligning, and we almost create almost like a quilt, I suppose, of all of the key strategy points in here that we also have a shared interest in those partnerships achieving, and that's what we monitor it, and we monitor it that way. Also, I'll connect with the officers that are running and leading those boards, so if they have those escalation points as mentioned, they're put straight onto the agenda for Somerset board to be aware of, and just have a bit more of a to and fro interaction with those groupings. But primarily in terms of a reporting aspect, those partnerships and their boards will have reporting processes in place for the strategy and plans listed. So my intention is to lift out of that reporting, the reporting that comes here, so we get a golden thread, but also we get a good contextual narrative around any of that reporting as well for the board to be aware of. I hope that picks up that.
Can I push a little bit though? Because it's not for us just to be aware of, is it? It's no good for us just to be aware that a partner can't do something. We need to be committed to say, okay, if it's my service or if it's our organisation that can't deliver something, we stand together, we come together and we work it through it. And it is a bit tricky because it's in public and sometimes that's tricky, but we have to have that principle that we're all committed as board members to unblock things that are not working, I guess.
Okay. Yep, go on.
Apologies, I paused mid-presentation and the conversation has moved on to some degree to what's on the later slides. So the next slides in the pack I won't dwell on too much, but it does just lay out what are on those rows as seen in the table with the lead partnership and the key strategies. Also already in there from what's in the Improving Life strategy, there are indicative outcomes listed, which again that working group would be looking at and looking at renewing and checking that they align. We can also check that the indicative outcomes that are Improving Life strategy are agreed and align with what the economic, so in this instance, the Economic Growth Board are looking at. Are they looking at the same indicative outcomes from their perspective? And is that aligned? And where are we missing one that they may suggest is a good indicator from their perspective. But as Alison said, where can we also hold them to account for where we'd like to see an outcome in terms of health and well-being in relation to productivity? We've put some indicative rags on these slides as well. Again, it was a precursor to starting to say we could start to accumulate this up into some reporting of something for the board. And the additional considerations from the strategy box, the blue box, is also just a flag that there was other things mentioned in the Improving Life strategy that we haven't necessarily found a lead partnership that has mentioned it in their strategies yet. So there may be elements of the Improving Life strategy that working group again may say, actually, we haven't found an avenue for the delivery of this aspect yet, or we haven't found a natural single place where this is brought about. So we might want, that's almost a gap in that regard. If I move on again, so this is the same slide for the second point in there. So there's one around communities and national neighbourhood working. Somerset's rurality is mentioned in the Improving Life strategy, but isn't necessarily something that's sort of in a single place. So again, there's almost some cross-cutting themes here that need to be reviewed as well as part of that status. And again, we've got Education for Life board being in place as a lead delivery partnership, and as well as Children and Families Executive Care Board, notwithstanding any changes, as Richard said, that may come in that area. And almost, as Alison said, we start to reconnect to those groupings. And then obviously the health and wellbeing, fourth priority as it is in the plan. There'll be some big changes coming in there in terms of the integrated health and care plan changes as a result of the 10-year plan and the impact that will have on the ICB and the delivery of that. So again, whistle stop touring through, apologies Chair, but I'm mindful of time. Again, so my intent is to, if it's agreed that that's good linkages out to those other partnerships, that I can continue to make those or make any new linkages that are suggested, start to flesh out what a potential monitoring and assurance report would be for this board on the Improving Life strategy, and bring that back in November. And that they can identify any issues and bring it to Somerset Board, and really just, I suppose, also raise the profile of Somerset Board to those other boards and partnerships, that they're aware that A, that we exist, B, what we're here for, and actually what our responsibilities are, and therefore what we require of them as partnerships and the work that they're working in. So the proposals I'll cover off, if you don't mind, Chair, in terms of that this strategy remains valid until it is changed in that regard, and a working group, it could be that it's agreed that it's the same working group as previously mentioned in terms of looking at the governance side of things, but the working group is established to look at the development of a new strategy, A, because of all the changes that are happening in the system, but primarily because its natural date currently on the strategy is 2028 anyway, so now's a good time to really start to lay the foundations for what a new strategy might look like. And that work, as mentioned, takes place to start to embed some of those requirements that have been, I suppose, signalled in the 10-year plan into any of our local strategies that are commissioning, that sort of stuff, in advance until legislation changes as such. Pause there.
Okay, so we've got those recommendations that are already been gone through on the screens. Richard.
Yeah, I just wanted to reflect a bit. This is a kind of business as usual approach, and and I wonder whether we're moving into a different space now. Yeah, we have some existential challenges ahead of ourselves, like in terms of the council, what does the shape look like? How are we going to transform in terms of the 10-year plan, the new kind of ways of working together? And I just wonder whether having 20, 30 different strategies that are all kind of about how, different outcomes we want to achieve, absolutely, for our population, is the right way to kind of govern and shift us to where we need to get to. And especially when there are kind of some real fundamentals that we need to get right, the kind of building blocks, and whether a kind of a shift in a local focus onto those building blocks might help us to then achieve what we want to achieve in the strategies better than just kind of starting at this level, if that makes sense. But anyway, so it's just a question as to whether the landscape, the public landscape, has shifted to the extent that we need to reflect that and maybe have a different way of kind of governing and managing what we want to achieve in Somerset and kind of what our ambitions are for the population.
Oh, sorry, the microphone on. Yeah, no, it's a good challenge, Richard, in that regard. I suppose what I've put up today is a way that we could continue to monitor the Improving Life strategy as is in that regard, and link to the partnerships as is currently, sort of thing, and that whatever work has taken place in that working group, when it comes through with new recommendations about what the new strategy would be, new recommendations about what linkages need to be into partnerships, if that group suggest those foundations, keystone measures, healthy life expectancy, things like that, as almost the North Stars have been mentioned previously. If they are flagged up as being the ones that the board should be keeping its eye most on, then absolutely that would start to drive, or even it be about that we're monitoring the transformation and transition to that transformation itself is what the Somerset board should be looking at, then absolutely we could take that forward and monitor that. I suppose what I'm putting forward today is a BAU. It is saying actually we've had a bit of a gap where we've had a strategy and this Somerset board hasn't actually necessarily been monitoring that strategy. So here's not a quick fix, but here's a fix for the monitoring of the now for the strategy as is, with the partnerships as is, but also start to explore those relationships, converse with those partnerships as well, because they are experts in their field as to what they think are good. So homelessness is a good example where housing will have a good understanding of what they think the health determinants around housing are as well. So it'd be good to sort of draw that conversation together in that regard.
Yeah, I'm just reflecting on what Richard said, and actually we shouldn't maybe rush to refresh the Improving Lives strategy. I think we need the key thing for this coming year, it feels like, is Paul's wise words. We've got to deliver this year, but also we've got huge amounts of change. So maybe we try and live a bit more through that change, have a bit more clarity about the future, and then be a bit bolder. There's statutory things we have to do as a health and wellbeing board going forwards, one of which is have a neighbourhood health plan. But then how we get delivery of that doesn't mean, I mean, I was very struck by the Community Safety Partnership workshop where they took a bold step and said, actually, we'll have objectives, but we won't lead them all. We'll trust different partnerships to lead the delivery of an objective rather than do everything in one place and then do, I don't know if I'm articulating it well, Bill, but it's just to sort of work in a different way, in a slightly slicker way. So maybe we need to take a bit of a pause and not rush to refresh the strategy before we've thought really how we want to work.
I'd rather agree with that because there's such a lot going on, and I'm not sure that we've achieved, what we've set out to do. I mean, I can't say that we haven't, but I think because so any linkages that you're now bringing forward and assurance, I mean, that would go to this board and then whatever replaces it, wouldn't it? I mean, it would still report forwards at some level, so that's important. So that, to me, one of the things I've found since doing adult social care is that there's such a lot of stuff going on. I'm not always sure how it all links up, and that's just within my my service. Boards all over the place, etc. But I think to try and pull together what you've said, as you've suggested, to show how that moves upwards up to the next level, which is perhaps this board at the moment may be different in the future. I think that's important. I think while we look at the NHS changes going on, it might be sensible just to wait to renew the strategy until we're a little bit further forward with that and the direction of travel is actually firmly established. I can see the point of what you're saying, Alison.
Yeah, I was just contemplating whether at the end of A we could say and evolutionary or something like that, because I think it will be an evolutionary approach as we go forwards at the moment. And we've got to recognise we've got a strategy at the moment, and we've got to recognise that there is a huge amount of transformation work going on, and there is a huge amount of structural change going on as well. And so just the words recognising that evolutionary change would help with that. I can see lots of nodding, so I come up with the right word. I was playing with fluid and flexible, and evolutionary felt better. Yeah, if we're happy as amended, and we're seeing.
Because it should remain. Yes, it should remain pertinent to what we're doing, but it also has the ability to alter.
I think that covers that myself. I think it just needs that it's not something that was taken down from the mounted on tablets of stone. Liz?
Just looking at B actually and taking out the bit after the comma, so a new strategy reflecting the changing landscape, both Somerset Council and NHS in Somerset, because if we don't, that working group is not charged with reflecting the changing landscape, it's going to get to a point in time and it may not be relevant at that time. That's the bit that worries me. When you're working in a changing landscape, it's no good putting people into a really fixed framework, because by the time they get through there, they're no longer relevant. So I think it's about reflecting that changing landscape.
Again, I'm seeing nods around the room. Sarah?
Just revising and updating the strategy, because I don't think we need a new strategy. I think we need to make sure it's still relevant, don't we? Because we might rephrase it or put it in a different way, but you don't have to start with a clean sheet of paper, do you? You just.
Oops, sorry, I didn't put my microphone on for that one with the recommendations though thus tweaked, and I've got Alison with another tweak.
Sorry, I just wanted to highlight that recommendation or proposal C is actually that there are specific requirements in the NHS plan that we will have to deliver. And so I think we need to make sure our tweaks include those. One of those is the neighbourhood health plan.
Yep, absolutely. Okay, well, I think we've reached a conclusion on wording there. Thank you. And moving on to the Safe for Somerset annual report. Heather, you're representing on this.
Thank you, Chair. Thank you, Bill. Yes, I am indeed. I'm a poor substitute for not having Lucy McCready, who's the lead officer for the Safer Somerset Partnership. But I am, obviously, I've got Sarah Skirton on the line as well, and a number of the people sitting around the room and at home are actually members of the Safer Somerset Partnership. So if I come out with something absolutely egregious, I'm sure they'll pick me up and help me with it. The reason I'm here is obviously I'm the, although I'm a children and families lead member, I'm the chair. I happen to be, not because of that role, but I happen to be the chair of the Safer Somerset Partnership. So what we want to do, we always bring an annual report. We have in the past taken it to adults and health scrutiny, but decisions were made this year, and I think rightly that it should really come here. I think the main thrust of what Safer Somerset Partnership and it's a community safety partnership. It's all about partnership working, and it's all about those wider issues about being ahead of issues, but also about working at a very kind of macro as well as a micro level to ensure we keep people as safe as we can for all kinds of statutory responsibilities. And that fits much better, I think, with this group of people than perhaps it does with the adults. No offence to the adults and scrutiny, they do a bloody good job, but I think we have the partners in the room here to hold us to account, to make sure that we're doing all of the right things. I think it's probably a better place to bring it. I'm going to assume that you have read it. Forgive me, I don't have any slides. I'm not going to do death by PowerPoint. I do apologise for that, but there's a 34-page report. I won't be quizzing you on it now that you've actually read it, but I think it's quite a helpful read. And I'll just take you through a few of the highlights from the main report that we've got, kind of the covering report, I should say. So essentially what it's about is actually summarising the Safer Somerset Partnership's activities. So we have strategic priorities around crime trends, key activities, funding, future plans. So it tries to give you like a real state of the nation on everything that falls into our bucket of statutory responsibilities, which the partnership delivers on behalf, if you like, of a number of the organisations involved. So, for instance, if I may just dive into the main part, I think that one of the things to say is highlights to bring from the report are things like, while statistically we are not a heavy crime area, we're below average, but there is a good deal of concern about crime, and unfortunately some of the crime types are increasing. So that is really important. We're always focusing on things like serious violence, sexual offences, robberies. They have all increased in number, as is antisocial behaviour. Well, even though there's a perception of antisocial behaviour getting worse, though sometimes the statistics don't actually bear that out, but not everybody reports crime. So we have to be really careful about things. I think what I wanted to also say, it does show a couple of things. It shows about how important early identification and prevention is. We've talked about those themes all the way through today, and the the role that plays. So I think that's really important that we could do that. We have some really good working examples, which our early intervention team, which is partnered up with the police and our safety teams, did fantastic work this year with supporting 200 young people who are at risk of violence, identifying them and then working with them. And it's that kind of proactive approach that's really important. Another one, we actually managed to get a non-strategic but critical incident response toolkit, which is really important, which we didn't have before. So we've been doing some really practical things as well as producing needs assessments and plans. What I think I've learned from being involved in the partnership since 2019 is the government seems to make it very happy. They're very happy to give us new responsibilities every day. So if you look in the report, you will see a long list of all the strategic statutory responsibilities that are devolved, if you like, to local authorities and to our partnership, which we as a partnership have to, in a sense, ensure gets delivered. So every year something new comes along, usually in response to some national crime wave or some concern the public might have. So we do have a lot of statutory and strategic responsibilities, most of which don't come with extra money. Most of these extra responsibilities are expected to be absorbed into the work of the councils and of our partners. So it's nice to actually get that one, I think, out for people to see, because I've always felt that we've done a good deal of work as a partnership, but without, I keep saying on a shoestring, which is a bit unfair. We've got a really good team now, and we do have some budgetary input now, but we have really big ticket items that we don't always get additional income for, and we've gone to our partners to give us some extra money to support some of those things. The example I use all the time is the domestic homicide reviews, which is the Home Office a Home Office mandated review, so that if any person loses their life and during that, before their life was lost, they had any involvement with domestic abuse, then we are obliged to consider that for a domestic homicide review. Very similar in a way for the safeguarding adults or a child death, except that it's got a very broad meaning, and therefore it's really hard to say no, that does not qualify as a domestic homicide review, and that then instigates a whole heap of work, which is the right thing to do because the person's lost their life, and we must make sure that if that was an avoidable death, that death should be avoided. So, but we're doing it really on the goodwill of our partners, which is appreciated. So, if I won't say too much more about it because you might have more questions than you want me talking about it. The only thing I would point to as well on the covering report is the risks. What we've been very conscious is on page 3 of the covering report. We have identified in our partnership working areas where perhaps we have not been working as well as we could do as a partnership, and we have been working incredibly hard to make that better. The first one is something called MARIC. Forgive me for the that should have been explained. That's a multi-agency risk assessment conference. Which is an approved way, if you like, a recommended way to bring all the partners around the table when there has been either somebody at risk of domestic abuse or has already suffered it. It's quite hard to bring all the partners together in a way that works very well. We've been working on it for years and we continue to work on it. And I've been really pleased by the way the partners have all pulled together to find one of the workshops, as Alison mentioned, was around how we can make this system work better. And so everybody can everyone can be involved but not overwhelmed. So that's it's an itchy thing, but it's very good. And I think also we have had some issues around staffing and so on and resources. So those level of risks, we're working on them all the time, but we're not saying this is a well resourced and a very sufficient way of doing things. We can always do it better. So, and again, I think the recommendations on the first page tell you a lot about the kind of points I'm making or we want to make with this. We do want to ensure that you have read the strategic direction the strategic direction that's encompassed in the report, and you're happy with what we're doing in order to try to both reduce crime and reduce reoffending and keep people safe in our community. We want to, we're asking really that you support the plan to review our partnership functionality and governance. The governance issue has always been a bit of an issue. Anybody who spends more than 5 minutes in one of the rooms like this will see there are a multitude of boards. There are a multitude of responsibilities. The same people turn up at all the boards. I've got Lisa Simpson's one of my fantastic colleagues, and a great supporter and a great partner in the partnership sphere. I see her with every hat on. and we see each other with every hat on. And so you end the same people in rooms. So we are working very hard to slim that down, to make it more streamlined, and also to make sure if people come into a room, I dread to think what the rate per hour is for the people sitting in here. If you come into a room for 3 hours, something sensible happens as a result of it. And we're not just talking about stuff and going, hey, yeah, that's a big problem. You walk away with actions. And that's a really big thing that we've been trying to do with the Safer Somerset Partnership and our partners collectively. Acknowledging that point number 3 is acknowledging the ever-changing landscape of community safety agenda. It is massive and it gets bigger every year. And that's the stuff that drops on us. I don't want to say policy, well, I'm going to say it, but making policies introduced by press releases and press conferences. So we have to act quite in an agile way to meet those needs. And oftentimes we get the requirement before we get the guidelines. And then just to promote the work that we do, I'm very conscious that we kept our kind of light under a bit of a bushel for a while. And actually the range of work that the partnership does is really important for all age. It's all age safeguarding and it's all age consideration of how we can work well together, from responding to a crisis or an incident all the way to how do we ensure that children can feel safe and young people can feel safe walking around their streets. So I'm sorry, I've waffled a bit there, and perhaps you would have liked a PowerPoint presentation, but I think the report is good and short, and it's really good. The actual annual report's a bit long, but it's got lots of good data in it. So I'm happy to try and answer any questions if people have got them. Thank you.
Okay, thank you, Heather. Any comments, questions, observations? Yeah, go on, Sarah.
This is something that I've only come in touch with since I've been doing my current role on the executive. I think that, I don't know how to do anything about this, but I think the agendas are too big for the meetings we have because it is really complicated. You're absolutely right, Heather, when you say that. There's a lot of work to be done. There's a lot of different people involved. And I think it would be helpful to have more focused meetings, possibly on a fewer subjects, then we could actually get to the bottom of them better. I think it's trying to cover so much, and there is a lot, and it's a big area as well. I just wonder if we could make it a little bit more focused. And you can see from the breadth of this report how much there is involved in this. And I don't envy you the task at all. But I definitely don't want to do your job in lots of ways. But I just wonder if we can have, I think if we had, shorter meetings with shorter agendas, and I wouldn't mind having an extra one to fit it all in. But sometimes I think, because if you have a long meeting, people just drop off, or I don't mean to sleep, I mean they just drop off the call, but your concentration drops off as well. And because it's a subject to me that I look at everything and I think, well, I don't really know much about this. I just wonder if we could make it more focused.
If I may come back, Chair, and I can see Lisa's got a hand up as well. I'm sure you're speaking her language and speaking mine too. I think it's absolutely right. I kind of inherited a kind of a quarterly meeting, and actually, I think you're probably right. Shorter meetings, more focused. Some stuff could actually be done as standing items, which we're trying to pull right back to. Here's your standing agenda item, which by law we have to provide you with, and we have to report back. They could be taken as papers, and then just anyone can ask, which we're trying to get to, just ask questions. But I think frequency, I'd really appreciate that. I don't know, I'm loath to think of more meetings for Lisa, but I get that idea. So I'll shut up and let Lisa come in if that's all right, Chair.
Yeah, Lisa.
Well, there are two things really, and thank you, Heather, for your comments as well. I think that and it speaks to the point that Alison was making in the last agenda item. It's not just about the expensive use of the resources in order to resolve the problems. It's actually about fundamentally linking up the work to give the most effective service to our communities. So not just the capacity of us and the expense, potentially the waste of expense. It's about joining up the actions and having an all-age approach to be it the health, the safety and the thriving of our communities, and we haven't got that right. That said, I think that there's an awful lot of work going on in the background to be reassuring here that fundamentally we need a business unit that joins this all up, because only in that and just looking at our calendars this afternoon, I haven't got access to all of yours, but there are definitely Somerset local authority based meetings and community safety based meetings that are operating next week, the week after, at the same time, where yes, we all want to be in, but actually we probably could halve them and join up the themes. There is, like I say, there is work. We've been raising this now for at least 9 months. A business function will bring that efficiency. I'm not the best person to comment on where we are with that, but that work is ongoing, and Duncan has been really supportive in that space to get it moving. So there's that. And then the second part, which was going to be the first part I was going to raise my hand for, was I can't fail to be present in this meeting and Heather be accountable for all of that bit about crime that appears in that report. So I can touch on points if people want to understand some of our responses to that, but largely I'm sure that there'll be concerns in the room around increasing ASB, increasing crime, and I'm just putting it out there. I don't expect Heather to answer those questions. I'm here for that.
Thank you so much, Lisa. I really appreciate that. I was just going to say as well on the point about the business unit or an executive, how you want to describe it. I think it was very. I've just about a week or so ago, I think, wrote out to all the partners to say, and how would you feel about that? And to almost everyone has come back saying, yes, that'd be a really good thing. Now that means a bit of work, obviously, but I think that'd be a really good thing to take that, and that's that joint ownership as well. So I think that'd be really good just to say. And yes, Lisa's absolutely right. There has been a deal of work that's been going on in the background, with great minds trying to find ways in which things can be made better. But it's a very messy landscape that we're all in terms of the times we bring people together. Thank you, Lisa.
Okay, any other comment? Oh, look, sorry, Alison.
Yeah, so thanks, Heather and Lisa, for the work you do. I think in answer to your question, I would say I am assured that the Community Safety Partnership is delivering its statutory aims. Having gone to one of the partnership, I saw a sort of an attitude amongst partners that recognised the challenges they were facing, were honest about them, and open to tackle those. So I think this board's function is to sort of ask the question, when you look at the graphs in the report, is crime is actually increasing quite significantly in Somerset compared to our comparator local authorities. So do you have the resources and the support you need? And if not, can you flag to us if you don't? Because that's what we almost need to know, isn't it? Because I've observed you deliver, but you might need to deliver more next year.
If I may say something before I bring Lisa in, I have the double joy that I'm also on the police and crime panel. So I do we're involved in, we get a lot of kind of statistics through there. So I was just going to say, there's two things. One is, I'm really pleased. The reason why I'm pleased the report's coming here is because I have a much more sensible place, or we have a much more sensible place for escalation. I think that's exactly right. I think the other one, though, and you can tell me if I'm wrong on this, Lisa, but I know some of the reporting changes may be, or the number changes in terms of maybe because the police force has gone through a real radical improvement on how they actually report the crimes. So how much of that is then affects those numbers, Lisa could tell me better, but I know there's a lot of work's gone on within the police to actually properly record, not that they weren't properly, but to record every crime when they attend a scene rather than just the principal one. But Lisa might put me right on that one.
I would have put my hand up, Heather, if you'd not said yes. It's true. A couple of years ago, even in Somerset, were criticised by our inspectorate around our ability to ethically and appropriately record crime. That's not to say we were trying to battle it under the carpet. We really weren't. It's just we weren't necessarily picking out all the specific crimes and recording them separately in things like, if we get called to domestic abuse, the hidden crimes in that can include specific child abuse, coercion, it can include sexual offences. And where we were wrapping it up and dealing with the victim in one case, and probably largely very well in those sorts of crimes, we weren't recording them as 5 or 6 separate crimes, but as one. So that's a very simplistic example. That meant that in the last 2 years, we've rapidly had to improve, rightly so, but the increases don't reflect necessarily, and I'm not for a moment saying we haven't had a slight increase in crime. We have, in line with every other local authority area, but it's nowhere near as significant as those stats would have you believe. I think the more important point for me now is that being really open, we are a very low performing force in positive outcomes for our victims. And that's what we need to focus on, is once things are reported, where we have strived to get to the most serious matters with the resources we have, we've made decisions, I think, to close lower harm crimes, but largely important to communities much too quickly. And the result is that we've got what would have been called a detection rate, a positive outcome rate, that's much lower than all of our most similar forces, and in fact almost bottom of the heap in 43 forces. So our focus is doing the absolute best we can for victims. Shoplifting's been in the news lately, you will have seen it. That's another good example. And I can talk about increased resources and our focus on that, but Chair, it's absolutely up to you what you'd like to know here.
I was just going to say, I'm pleased to hear you say that one, because I would have mentioned the positive outcome bit, and it's really important bit. But it's like anything. The reassuring thing for me, or assuring thing for me, is when you fall over something like the question you've asked, Alison. We're kind of on it, and so you haven't got the answers necessarily, but we're trying really hard with it. But I think that's important, and certainly it's those things. It's that perception of community safety and that perception of community health, actually, in its widest sense. That's where, the big ticket items, the sexual offences, I know a lot of effort is going into that. A lot of effort is going into serious crime of all sorts. The stuff you don't see, all the fraud stuff, as much as you can. It's the smaller stuff around communities, which is where we bump into it here, and it becomes a perception rather than a reality. So I want to say on that one.
Yeah, I'm interested in this because I think that the lack of respect for law and order is a societal change, and it's something which the police and other services have to grapple with. Interestingly, well, again, at the parish council I was at last night, they had some antisocial behaviour in their village green, and to these children or young people, you cannot behave like this in public. And the parent of one of the children said, well, I didn't know they were doing it until that happened. And actually it stopped. And that was just simply somebody just saying, you can't do this here. It's not right for our community. And I'm not suggesting that members of the public need to go and do that sort of thing, but there does need to be a bit more, reinforcement of what we do about obeying the law amongst our communities, because, it's done by consent in this country, and that's the way we want it. We don't want to keep making more draconian laws about people and things all the time. And that is across the piece. It's across education and all our other institutions that, and I know you have it in A&E, have people behaving badly. Well, they shouldn't be treated, frankly, in my view, if they're going to start causing problems. So, I think it's a societal change, but I'm glad to see that our figures are not mushrooming. But I do feel for the police and those trying to enforce that this is a hard task to get it right.
I'm keen to move on to the recommendations, and well, I know we could discuss this all day, but I see we've got somebody who's not spoken online. I'm just juggling screens. It's Angela. Hello, Angela.
Thank you, Chair. I just wanted to also add a new dimension here, which speaks to Heather's earlier point about the changing landscape. Across the voluntary community sector, we are seeing increased hate behaviour and hate speak aimed at any of the charities and voluntary groups that are supporting migrant communities or other faith communities. And it's affecting our workforce. And the comment that's just been made about badly behaved people in the NHS, I think it will be relevant there. So particularly on Household Support Fund at the moment, Citizens Advice and other partners working that programme, we are getting some very aggressive, hateful, really distressing comments made to us about people in Somerset, mainly of white ethnicity, believing that there's no help for them and it's our fault, the frontline services fault, because other minority ethnic people are getting the help. And I think it will increase before it gets better. I just wanted to add that it relates to workforce, it relates to volunteering. It's not hate crime, but it's going in that direction. We might see some more hate crime figures. Thank you.
Yeah, and the police have just issued CCTV of two gentlemen they want to speak to in connection with the attack on the mosque, and you just take all the underlying things, that's where it leads to. And you know, it is a distressing situation. I know that we're working with faith communities to be able to address that separately. One last comment, Heather, and then can we move on to the recommendations, because there's another meeting in here this afternoon.
I appreciate, and I'm really sorry to say that, but I think that point that's just been made, I think, is really good. I think also there's another one I just wanted to mention, which is that the right care, right person, I think it is the right phrase, which is that idea that about how the police are used is a really important thing, which I think this group probably needs to talk about at some stage, perhaps on another agenda. Because one of the things that was always scary for me was when I heard people say from the police that actually the percentage of 999 calls that are actually pertain to a crime is massively low. It's about 33%, I think, of every 999 call pertains to a criminal, possible criminal activity. The rest is something else. So I would just think something I should have said in my introduction was, I think there's some subjects we should bring back as to be discussed here if we can find solutions for them. I just want to raise that one.
Just one sentence, Lisa, please.
Don't worry, I'll pick it up another time. It would be more than one.
Yeah, thank you. I'm just very conscious that we're approaching an hour behind schedule, and I understand that the next meeting has a protest at it, and which will be terribly exciting if we're still here. So we've got recommendations to endorse the strategic direction and priorities of the partnership, noting that these priorities will remain the same until 26-27, supports the plan to review the partnership functionality and governance, acknowledges the ever-changing landscape of the community safety agenda and the necessity to monitor opportunities for collaboration and promote awareness of the partnership's work across networks. So we are all happy with those recommendations. Okay, that's clearly agreed. So we move on to agenda item 10, SRO updates, and I think we've got Lucy and David presenting. Good morning, good afternoon, good evening. No, where are we? Good afternoon. That's all right. Lucy.
Just afternoon, aren't we? Right, bear with me. Let me just share my screen. I think, shall I share my screen? Yeah, perfect. Go through it. Brilliant. Okay. So a bit of a quick update in terms of linked data and the work that we've been doing over the past year. I obviously came to the board last October and presented the approach that we were looking to take wider across the sort of digital data and technology strategy, but also very much focused on a sort of data platform approach in terms of delivering value across partners with that linked up data. I do want to be really, really upfront at the beginning to say that we are doing this alongside some really major programs of work that are happening in organisations already. So I think that's really important to state. So the electronic health record within Somerset Foundation Trust is obviously a significant programme of work that's going on. And the new data platform that's being pushed forward at the moment to increase the stability of Somerset's data infrastructure is going to be absolutely critical in the future as well. So I just wanted to be really clear to the board here that whilst this is a really important programme, it relies on all of the really good work that's happening at an organisational level to enable this data to flow. Okay. I'm going to bore you, I'm afraid, with various different diagrams, but I think the really critical thing is to show that we're all joined up. And I think, again, that's really, really important to state here. Everybody has their own data challenges within their own organisations. Our particular data challenge in terms of the work that you've asked me to do is to bring that data together and to link it and to make sense of it. So that we agree some standards around how we're going to treat certain aspects of that data, and that we all agree a way forward in terms of how that data is potentially structured and shared. So I want to be, again, really complimentary to everybody that's been working with us as a team. We've had huge engagement from all the teams in different organisations, you know, and I won't go into sort of detailed name droppings, but I've got one of them behind me. So thank you, Josh. So there's been some really good work done, and I think what's really clear is the approach that we're taking with the linked data platform. And I will talk a little bit in terms of the technical terminology. The whole point of it is to make data accessible, right? The whole point is to allow data to flow in the best possible way. So this is not about creating a system for the whole partnership. This is about making sure that we can link data and push data so it's valuable to every part of the system. So all of the good work that's happening at a local level within your organisations are going to benefit from the work of linking up this data and sort of pushing it back in. And particularly the work that's going to go on around neighbourhoods. And I think that's a really exciting opportunity for us in the future in terms of linking up that data. And there's some amazing dashboards that have already been built, both by the council and public health, and indeed by other health colleagues. And it's about bringing all of that into one place so it's accessible and useful for those neighbourhood teams on the ground. What we don't want is a scenario where we've got multiple different dashboards that everyone has to log into. So it's really important that we take a very kind of pragmatic and more partnership focus to surfacing some of this data as it goes through. I think the other thing to point out, and I just wanted to sort of put this forward, this has not been agreed yet in terms of a sort of a national or data or regional view. But one of the things that we have been doing is working at an ICB level, trying to understand what the future might look like. And actually, is there an opportunity to replicate all of the good work that we've done in Somerset in other parts of not only the cluster, but across the region too? And that could be hugely beneficial, because actually what we're doing is we're creating a set of standards that would help at a regional level and potentially at a national level too. So we're kind of taking that front view, I suppose, of creating this infrastructure for that region, for the region. So quite exciting, and we should be very proud of that. One of the things I mentioned in the update last October was, and you know, I know people don't get very excited about governance, but governance is obviously super critical and important, and particularly when we're dealing with such high risk sort of data, particularly personal identifiable data. So we have a new governance structure for digital data and technology across the ICS now, where we have membership from all of the different organisations, and that was signed off at the collaboration forum last week. So that's really good news. We have a way to be able to track and manage and understand things as they move forward. And obviously that's going to be an evolving piece of governance as the changes come through with both the cluster and understanding, I suppose, the implications of the IHOs, etc. So very much an agile approach, but at least gives us that coverage whilst that linked data platform and the other organisational work is going on. One of the critical things that, again, I want to point out is that there has been a huge amount of work in terms of getting the IG right for all of this. So data sharing agreements have been signed by numerous partners now. We have also got joint controller agreements in place as well. So there's a substantial amount of governance in place in terms of getting this data to flow. The other critical part of it is obviously having a conversation with our communities and making sure that they're aware that we're actually starting to bring this data together. And I think that's a really critical thing. We will be going out for Section 251, and we're hoping to go out for Section 251 approval across the cluster. So it will include Dorset colleagues and obviously BSW, sort of the agenda as well. And that makes sense if we're all following that same infrastructure approach. So that's what we're trying to do. To get that Section 251 approval, There is obviously significant community engagement that we have to do, and we're starting that at the beginning of this month. We are going to be working with Healthwatch. I appreciate they've got a limited time to support us, but we will be working with Healthwatch. We're working with the GP practices on the ground, and we're obviously linking up with you as partners as well to try and get that message out there and try and communicate the activities that we're about to undertake, critically allowing people to understand that they can opt out of this process. And finally, I just thought I'd give a little bit of an update in terms of progress. So huge amount of work on IG. So thanks again to all IG colleagues across the ICS, significant amount of work done there. We're in discovery at the moment. So all of the technical tests that are taking place at the moment around how we handle things like ethnicity, coding and postcodes and location and all of that sort of detail that needs to sit in a linked data platform is happening at the moment. We're just coming up to the end of week 2, and I can't tell you the joy I'm feeling on a daily basis seeing code actually being put down. So you've got me in a very bouncy mood today. So that's really exciting. Obviously, community engagement starting from this month, and then we have the full production linked data platform build starting in December, which is really exciting, with a plan for that to be live with all data sets from March. Any questions?
Seeing any, which can only indicate a very comprehensive report. Thank you so much. That's really has been absolutely fascinating. I'm really pleased to hear the progress that we're making there. And I can only imagine how the frustrations, but there are other parts of the system that aren't quite organised yet as we move towards a brave new world. So thank you so much for that, Lucy. And then David, neighbourhood working updates.
Yeah, thank you, Chair. We did a detailed update last time. So just a brief update today. You'll be pleased to hear. And we're going to do a more detailed update the next time we meet. We touched on this already. I was going to cover 3 areas really. We touched and used the analogy really of top down and bottom up in terms of approach to neighbourhood development. So in terms of that top down piece, there's clearly a lot of sense making to be done at the moment, and taking some of the national drivers and the policy tools that we've got and trying to work through how we're going to kind of adapt those for local use. So Duncan mentioned earlier that sort of work that he's progressing with the NAPC, and his other conversations taken about how we take some of the opportunities that are there and shaking up the entire system all at one time and making best use of that for Somerset. So just a bit of reassurance around that. At that top down level also is a sort of aspect of join up, and Heather, your point earlier about the join up with the transformation plan within the council. There's been discussions during August around aligning those two and being able to progress that, and also within that stretch the vision of what we can do at a neighbourhood level across health and care and the wider council services potentially. So that link is there. There's a lot of work to be done in taking that forward, but that's a good step forward. And then there's other links being made as well since the last time we met. There's a coastal place partnership being established. The first meeting of that's today, and we're linked into that as well. So there's not duplication around purpose and some of the geographies that we're progressing. So that's the kind of top down bit. The next step in that is to do that sense making and to be able to come back for the next time we meet and be able to explain how that's progressing. The bottom up aspect is the building blocks. So we need to keep an eye on where we're going longer term, but there's some fundamental building blocks that we said before in the framework that we brought to the last meeting need to be put in place. And we spoke about the data just now as essential. The other bits, we've got some leadership coaching, which is progressing with the PCN teams. I've also got some conversations about kind of PHM tools and how we can bring the data to life. So the point we talked about earlier in terms of the public health information and how you also build on that from other information sources, and how you start to predict if you made an intervention with some parts of the population, what that can do in terms of their health and outcomes, and also what it can do to the cost of care. We'll be piloting a tool in the next few months around that, subject to funding. So there's kind of a number of those building blocks. I'm not going into more detail on those today, but I'm happy to do more of a briefing the next time we meet
on those. And then just the final point I was going to make was around that link, which Alison's made previously. There is a bit of an opportunity as we reset what the ICB does in setting out strategic outcomes and stepping back a little bit more from the how we do things. At that sort of commissioning intentions round is upon us at this point in the year. So there'll be some certain amount we can progress that joined up across health and the council for this year, but then also look into the future. How do we get that seamless link between setting outcomes and through the contracts that we have, and then also being able to kind of monitor the progress of those linked back to JSNI, so that's a live piece. So all those conversations are in flight at the moment. It feels like there's a big opportunity to get it right, and I think that's the kind of the focus that we've got upon ourselves at the moment. So I'm happy to take any questions on that. As I say, it's a brief update today. There's a slide in the pack, but I'm happy to take any further questions today if we're out of time. Happy to pick up outside of the meeting as well.
Thank you, David, for the updates. Not seeing anyone indicating. Nobody online. David, thank you very much. Again, very clear. Thank you for the update. Thank you. There's an information only item, which is to receive the Health Watch annual impact report. Just to signpost that to colleagues, and to note that our next meeting is on the 25th of November, 10 AM, back here in the Luttrell room. Thank you, everybody, for your presence and your contributions, and we've managed to catch up time for those who wanted the next meeting. So thank you so much, and safe journey back home or wherever you're heading. Thank you very much, everybody.